Good afternoon, everybody. It's already 2:16, almost 2:17, so those of you who are still standing up, I would ask you to find a comfortable seat. We have a number of seats available up front. Don't hesitate if you want to see the interesting slides that will be presented this afternoon. So we'll start in 1 minute. All right, let's start. Good afternoon, everybody. My name is Robert Bissonnette. I'm a dermatologist from Montreal, Canada. I'm the current president of the International Eczema Council. It's a pleasure to welcome you this afternoon, welcome you to Milan. So I know some of you flew this morning or yesterday night, so we have a very interesting session for you. So I'm convinced that you will find it very interesting and you won't fall asleep at all. The title of this symposium is Customizing the Treatment of Atopic Dermatitis for Diverse Populations. So as usual, we are recording this session. So this session will be available online on our website. We always do this at all the sessions that we have at meetings. Even though we have an interesting number of people in the room today, this session will be viewed by many more people online in the next months or even years. So we can skip this one. For those of you who are not familiar with IEC, IEC is a nonprofit organization that was founded in 2014 by Amy Poller and Emma Gutman. We currently have 125 atopic dermatitis experts from 28 countries across 5 regions around the globe. So what you see on the map, everything that is in orange are countries where we have counselors. Everything that is in gray are countries where we don't have counselors. So if some of you have a strong interest in atopic dermatitis, if you have published on atopic dermatitis, you're conducting research on atopic dermatitis, you're giving talks on atopic dermatitis, and you live in one of those great countries, and if you're interested to join IEC, please come up and let us know. Disclosure, IEC exists in part because we have corporate sponsors. So if some of you in the room are working for a pharma company, if the name of your employer is on that list, we thank you. Thank you for supporting IEC. Without financial support, this type of symposium would not be possible. If you are working for a corporate sponsor and your name is not on the list, please don't hesitate and come and talk to us. IEC is a very active organization. We have numerous committees. In addition to our board of directors, we have an executive committee, a nominating committee, education, membership, finance and audit, and research committees. We're always looking for counselors and associates to be more involved. So if you're an IEC member and you're not active on one of those committees and you would be interested, please let us know. There are regularly vacant positions that are becoming available. I want to thank specifically our education committee. Since IEC started its activities, it has been very, very active in education, and I'll talk a little bit about that in the next few minutes. So I want to thank specifically our co-chairs for the IEC Education Committee, Nick Reynolds, who's also a co-chair today, and Valeria Aokai. So this is a list of our board of directors. I want to draw your attention to this name here. All of you know Alan Irvine. Alan Irvine is the current president-elect, and he will be talking to you in about a year and a half at our various events when I will no longer be president of IEC. I already mentioned Emma Gutman, who's one of our co-founders, and Amy Poller, another one of our co-founders. So we've been very active in 2021. We started the year mostly by virtual programs. As all of you know, because of COVID-19, the possibility of having in-person events was fairly limited. We had our first hybrid in-person event in 2021 at the ISDS on AD and alopecia areata. And then 2022 was mostly in person. We had a very interesting symposium on diagnosis and management of non-atopic forms of dermatitis in the AD patients at EADV. We had our first presence in Latin America. This was a virtual meeting at RADLA. We had an in-person symposium on microbiome at SID. We're here today, and we will be in a few weeks at ESDR with a symposium on single-cell technologies applicable to atopic eczema. Some of the things that came up in the past year and a half, we have an IEC bursary program now. This is intended for dermatologists and allergists with a strong interest in AD that are working and living in lower-income countries and for whom it would be difficult to attend one of the major meetings, such as AAD, EADV, or World Congress of Dermatology. If you know people who are in this position, they can apply, specifically because of the World Congress of Dermatology that is coming up soon, up to $3,000 in reimbursement for travel expenses. IEC has launched fellowships last year. We have launched a in-person 12-month research fellowship, as well as our first 1-month clinical fellowship, followed by 11-month virtual. This year, we've announced 2 more clinical fellowships. Dr. Wang, who will be working with Larry Eigensfield, and Dr. Mann, who will be working with Amy Powler. Something new as well, now IEC is officially open to allergists and dermatologists. So if some of you in the room are allergists, you have an interest in atopic dermatitis, you're active in the field, and you would like to become a member of IEC, I would invite you to send an application. And this is my last slide. So I'll be introducing you the 2 co-chairs today, and they will introduce the agenda for today. So I'm pleased to be able to introduce the 2 co-chairs, because yesterday we were a little scared that Dr. Reynolds may not have been able to make it. His flight got canceled, but he's here today, so I'll be able to introduce both. So Professor Reynolds is Professor of Dermatology at Newcastle upon Tyne, England. His clinical and research interests center on atopic dermatitis, psoriasis, human model of skin diseases, and precision medicine. Dr. Reynolds runs a dedicated tertiary referral clinic for adults with atopic dermatitis. He has been involved and led many randomized controlled trials in atopic dermatitis. Professor Reynolds is also president of the European Dermatology Forum and a board member of IEC and co-leads the Education Committee. Our second co-chair is Dr. Emma Gutman, who's immediate past president of IEC. She's the system chair of the Department of Dermatology at the Wallman Professor of Dermatology and Immunology at the Icahn School of Medicine in Mount Sinai, New York. She's the director of the Center of Excellence in Eczema and the Laboratory for Inflammatory Skin Diseases. Her main research focuses on atopic dermatitis and alopecia areata. She made some paradigm-shifting discoveries in the immunologic basis of AD, which increased our understanding of the disease and opened the door to pathway-specific drugs. Dr. Reynolds and Dr. Gutman, the floor is yours.
Great. Thank you very much, Robert. I'm really delighted to welcome you on behalf of Emma Gutman and myself, and to introduce this distinguished panel of speakers which we've collected for this afternoon. So we're looking forward to a really exciting session. As you're aware, there's increasing interest in precision diagnostics and therapeutics. We've seen the real development in this in cancer, but increasingly now it's being applied to inflammatory skin diseases. And not only is this being thought of as an individual patient level, but we're also thinking of endotypes in terms of populations or groups, and we're aware that the genetic and molecular background of these populations may differ, which may therefore account for their differential therapeutic response and different diagnostics. So that's part of what the focus is around. Within the booklet you've got today, there are quite detailed biographies of our speakers, so we're going to keep intros relatively brief, such that we can spend more time listening to the interesting science that's going on. As you'll see at the end, there's a 30-minute discussion session, so there's plenty of time to ask your questions. You can either save these to ask them or enter them onto the chat, which will then come up to us at the end, and there's a panel we'll try and get through as many as we can. So we hope it will be really interactive. And so please do ask questions in whichever form you want. So Emma's already been introduced by Robert, so I'm not going to repeat it, but apart to say that she's obviously well known to everybody as one of the leading lights in atopic eczema clinically and research-wise. And her focus is on pediatric AD and also in terms of adapting non-invasive diagnostic testing in terms of tape strips and how this may then distinguish the endotype. Thank you very much, Emma.
Thank you so much for this very kind introduction, and thank you for being invited to speak here and be here with you. I'm very excited, first of all, to be here in person at the EADV after a few years. Now, how do I get to my slides?
They should come up automatically, I was told.
Sorry
Next.
about that.
Next, please.
Good. Okay. So very exciting agenda, as you see, and we'll do introductions later to save a little bit time. And we have a very long panel discussion, and feel free to ask any question during that time. Now let's, so how do I get to my slides, though? Sorry, bear with me for 1 second. Okay, perfect. So very exciting times for atopic dermatitis now after we had a lot of developments for adults. Now these developments are coming to children, and more will come in the next future. So pediatric atopic dermatitis, all of us see as well as clinicians, but maybe we don't think about the idea that this is the most common inflammatory skin disease we see in children. 15 to 25% of the children, depending on the age. Often it presents in infancy, and usually it persists into adolescence and adulthood. And around, give or take, 20% of the patients will have moderate to severe disease. So a huge unmet need for better long-term disease control. We did have drugs to treat our patients, but for short-term disease control, not for long-term chronic control, because again, now we understand that the disease is persisting into adolescence and adulthood. So all of us know that now the therapeutic drought is finally coming to an end, and still the field is evolving with new treatments coming to both adults and importantly to children. Now, what prevented the therapeutic development in atopic dermatitis in adults and also in children? The fact that it's a very complex disease, a real multifactorial disease, and drug companies didn't know what they should go after. Should they go after immune abnormalities, after barrier abnormalities, and to complicate things even more, there is a microbiome component and itch that is also very important. However, now we know that all of these play together to create the disease phenotype, and targeting the immune abnormalities usually will resolve the other abnormalities in atopic dermatitis. So let's review the barrier abnormalities in AD and the clinical correlations. Regardless if we see an adult or a child, usually lesions will be lichenified, very similar to psoriasis lesions with epidermal hyperplasia. And when you stain for two proliferation markers, keratin 16 and Ki67 in chronic AD, you see, very similar to psoriasis, this widespread staining in the epidermis, both Ki16 and Ki67, and the same you'll see in children. Now, importantly, when we talk about barrier defects, we of course need to mention terminal differentiation measures such as filaggrin, loricrin, that are defective in AD. See in normal skin this nice line that is continuous, and it becomes discontinuous already in non-lesional skin and completely defective in lesional AD, and the same with other barrier measures such as tight junctions, claudins, and lipids are also decreased in atopic dermatitis. And clinically, what do we see? We see dry skin not only in lesional AD, but also importantly in non-lesional AD skin that has also increased transepidermal water loss. Now, importantly, invariably, in atopic dermatitis lesions, we always will see immune activation of type 2 cytokines and also type 22 cytokines. Here I'm only showing, due to lack of space, only type 2 cytokines, but type 22 are also elevated. We see this increase in IL-4, IL-13 and IL-31. Already in acute disease, it's elevated, more in chronic stage, and the chemokines associated with the type 2 pathway, and also IL-22 and the S100s from the type 22 pathway. Now, what role do these type 2 cytokines have on the barrier? So basically, there is important work done by Donald Leung and others in cultures of keratinocytes that show that alone and together these cytokines are able to downregulate important barrier measures such as filaggrin, loricrin, involucrins, also claudins, and lipids. And also antimicrobials are also downregulated by IL-4 and IL-13 alone and together. And why is this important? Because both adults and children with atopic dermatitis will have infections and colonization with staph aureus. Now, we need to remember there is this very important interplay. We still do not know fully what's the chicken and the egg. Although I'm biased, I think it's more the inflammation that causes staph aureus colonization and infection. But regardless of that, there is this vicious cycle between the type 2 and 22 inflammation in staph aureus that induces the skin inflammation and barrier alterations, and we have to break that cycle. Now, importantly, important work from Brian Kim that is in China as well, it showed that type 2 cytokines, IL-4 and IL-13, are really important mediators of chronic itch in atopic dermatitis. And by targeting them, you, of course, we know, reduce a chronic itch. So to put it all together, work in adults showed that type 2 and 22 inflammatory cytokines link the skin barrier dysfunction with immune activation and itch in atopic dermatitis at all disease stages. It already starts in the non-lesional skin, where we have increases in multiple immune mediators, continues to acute disease with a progressive increases, and this is amplified in chronic stage, and I'm sure you'll recognize many of these markers as being either approved or actively targeted now in clinical trials. Now, importantly, type 2 cytokines affect beyond the skin a range of other organs that share common pathomechanisms. So we have in the skin now several diseases that have some shared mechanisms. We know about atopic dermatitis, but now we have prurigo nodularis being added, bullous pemphigoid, urticaria, and we added also alopecia areata as being part of that type 2 comorbidity. And we have in other organs food allergy, EOE, asthma, and others. And they all have barrier defects that are similar or a little bit different than atopic dermatitis. Now, I want to ask the question, and this will be the main part of my talk, pediatric AD. Is the pediatric AD phenotype similar to that we know from adults? Why am I asking this question? Because children have distribution that is different than adults. Pediatric AD involves the face and the extensor surfaces, whereas in adults we see a little bit different distribution. You see the chest, the back, the flexor areas. And I have a very long-standing collaboration with Amy Paller, and a lot of the work you'll see is a collaborative work in which she enrolled the patients, we enrolled the adult patients, and we did the mechanistic analysis. So let me show you what we've done. We took for this study skin and blood, and only Amy Paller can do this impossible. She managed to get not only tape strips that are minimally invasive, but she managed to get even biopsies from children. And when I say children, these were infants, 0 to 5, 6 to 11, adolescents, 12 to 17, and we recruited the adult patients for the study. We had biopsies, we had a flow cytometry in blood, we had serum for a proteomic analysis, and we had tape strips, and I'll show you the results today. And I think this would lead to some personalized medicine approach that we need in atopic dermatitis. So the first study we've done was a flow cytometry study, and here you see children versus adults. The children here are infants, 0 to 5. So we first wanted to compare what happens in early disease. When I say early disease, these are children within 6 months of the initiation of the disease. Most of them were less than 2 years old. In fact, the majority were less than 1 year old. And we compare to adults. So what we see here, we see already activation of Th2 cells in blood in early atopic dermatitis, but there is a difference between adults and children. What's the difference? In children, we see only the cells that are homing to skin, the CLA positive cells marked by cutaneous lymphocyte antigen positivity, whereas in adults, also the systemic cells marked by CLA negativity that are producing IL-13 are also upregulated. So adults have systemic inflammation. Children very early on do not have that systemic inflammation. We also saw in adults activation of CD8 positive producing IL-13 cells, and we did not see that early on in children. Now, importantly, in children, we didn't see Th1, Th22, Th17, or Th9 subset expansion as we've seen in adults. So early on, atopic dermatitis is only about Th2 activation. Now, we also looked into what happens, when is the systemic upregulation of Th2 cells? When does it happen? So for this, we included in the study not only infants, but also children and adolescents and adults. And we see that already in children, there is this increase in systemic cells. Pay attention, you don't see that in infants, but the increase happens in children. So you need to think about that when you have a child with systemic or severe disease. You need to think about systemic treatment for these children. The other thing that we saw is that the skin homing Th2 cells are quite similarly, I would say, elevated across all ages from infancy to adulthood. So to summarize on this part, I think I convinced you that type 2 inflammation is common across all ages. And we see increased IL-22 and increased interferon gamma producing cells with age, with chronicity towards the adulthood age. Now let's move on to the biopsy analysis. Again, unbelievably so, Amy Paller managed to get biopsies from all of these ages. So we had biopsies from infants, children, adolescents, and adults. We've done gene expression studies and immunohistochemistry. I will start by showing you the data only from infants versus adults, and I'll move on to show you across all ages. So we were really surprised to see already in infants 0 to 5 with AD, and remember these are children with AD within 6 months from initiation, hyperplasia that is quite similar to adults, and in fact even more hyperplasia in the non-lesional skin of children compared to adults. Pay attention to the keratin 16. It's higher in non-lesional skin of children compared to adults, and similar epidermal thickness in children and adults. Also, at that very early age, again, these are children 0 to 5, we see really large increases in Th2 cytokines already at the initiation of disease. And again, pay attention to the non-lesional skin. We can view the non-lesional skin of infants as maybe true disease initiation. They have higher levels of IL-13, so the main cytokine of the Th2 pathway. IL-5 is higher. Pay attention to IL-31, the EAT cytokine, highly elevated in the non-lesional skin of infants more than in adults. What was the difference between children and adults? There was absolutely no Th1 activation early on in infancy compared to adults. You see the upregulation in both non-lesional and lesional AD in adults. That was completely not there in infants, so no Th1 axis activation in infants. Now, we expanded the study to include all the ages to see what are the unique and common characteristics of each one of the phenotypes. And this is a Venn diagram, complex Venn diagram that includes infants, children, adolescents, and adults. And I want to show you the core phenotype. You see, there is a core phenotype to all the phenotypes. This core phenotype has similar characteristics. It has increases in Th2 markers, including CCL17, CCL22, 26, 18, IL-13 is there, and IL-4 receptor. These are shared across all the ages, and also Th22 markers, including the S100s and IL-22. Now, you'll ask me next, what's different, right? So, at disease initiation in infants, we have several unique markers, IL-5 and IL-33. We already know that this did not work in adults, right? There were studies with IL-5 and IL-33, it didn't work. So the reason may be they are not there in adults. They are unique in children. And Th17 was increased only in infants. On the other hand, what is unique to adults? The Th1 markers are unique to adults. Now again, when we did a pathway analysis by a subtype, you see here infants, children, adolescents, and adults, we found similar upregulation compared to controls, and the controls are of each age, of Th2 markers, and this is the entire pathway, not only in lesional skin, but also in non-lesional skin. And we looked at multiple pathways that are available online from the Broad Institute and others. And here we see also that there are similarities, but there are also differences. Interferon gamma signaling is more unique to adults, whereas Th2/Th1 differentiation we see in children, and increased cell cycle and metabolism is more unique in infants when there is more proliferation. Now, what about epidermal barrier, right? This is a main feature of atopic dermatitis, so we wanted to know what are the differences there. So we see that terminal differentiation abnormalities are increasing throughout the age, so less abnormalities earlier in life. There are some, but less. It increases in older age groups, whereas lipid abnormalities are much higher early on in infancy, and there are less lipid abnormalities later on in life. Now, what happens in the circulation in terms of proteins in the circulation? So we followed up with an Olink study in serum, and we looked at 375 markers. You can do different series. We thought that this is representative of atopic dermatitis, and we included these phenotypes. And what we saw basically two clusters. Early on in the initiation of the disease in infants with AD, we saw some IL-17 related measures and some inflammatory measures already increased in infants. However, the markers that we usually are used to see in adults, Th2 markers and also cardiovascular related markers, increased gradually towards adults, and they were already increased in children. Again, children already have that systemic immune activation. Now, I'll end with my favorite topic. When we want to sample children, it's not realistic to do biopsies. I mean, Amy did an amazing effort here with biopsies, but we cannot expect people to do biopsies, and parents will not agree to biopsies, and biopsies are also not feasible in the context of clinical trials. So we worked very hard for a few years to really optimize a tape strip analysis that now works really well. We can do gene expression studies, we can do protein studies, and here I want to show you infants compared to children and adolescents, and we published extensively. You can read our publications. And here I'm comparing infants, children, and adolescents, normal skin, non-lesional, and lesional from each one of them. So when you look at the first panel, these are barrier genes, and you see in infants, you don't have much downregulation of these genes. There is some, but look later on in childhood and adolescence, you see much more dysregulation of these, very similar to what we've published in biopsies. Now, what happens to immune genes? This panel, highlighted here, these are immune genes. These are actually upregulated across all the ages. Of course, there are some differences, but all of them show increases. And key genes to atopic dermatitis like CCL17 and CCL18, our favorite Th2 chemokines, are there. The S100s are there. So the core phenotype we can actually evaluate via tape strip. So it becomes a very useful method in order to sample the disease, not only in children, also in adults, but definitely in children where we need such an approach. Now, I want to also show you that tape strips are useful not only in lesional skin, but even in non-lesional skin, and I like this word cloud representation that our bioinformatician did that shows very nicely, and here the words are basically equivalent to fold changes compared to controls. And you can see already very early in infants CCL17, CCL26. In infants, we also have TH17 activation, so you see CCL20, and F8-age is a lipid, so you don't really need individual lipid studies. You can actually, by gene expression, you can get to the bottom of lipids, you can see a terminal differentiation abnormalities, pay attention, filaggrin is there, Claudin 8, and you see that this carries forward to children and adolescents. Each one has a little bit different phenotype compared to the other one. So now I want to switch gears at the end of my talk and ask, how are we testing the contribution of type 2 immune axis to the AD phenotype in infants, children, and adolescents, and hopefully in the future we'll test other immune axes as well with other treatments. So we are doing it very similar to what we did in adults through clinical trials with targeted Th2 treatments in AD patients. And right now we have a dupilumab that is now approved in the pediatric population, adolescents, we have in children, and even in infants. Dupilumab targets both IL-4 and IL-13 because it targets the receptor. And again, we know that IL-4 and IL-13 are involved in the barrier disruption in atopic dermatitis. So I want to show you very briefly the results of the Liberty AD PEDS, the 6 to 11 with severe atopic dermatitis, and these were really severe children. Pay attention to the comorbidities and how many of them had comorbidities and the percent body surface area. And the results are really nice. EASI 75, around 70%, depending on the dose, and IgA 0/1 around a third. And as treating dermatologists, I think we care when we look at the treatment, not only that it works, but hopefully it will maintain or even hopefully improve over time. And this is the case here. That's good news for our adolescents and children with atopic dermatitis. What about safety? Very similar profile to the safety we see in adults. We do see conjunctivitis, very similar to the reports in adults. But importantly, and particularly this is important in children, we do not see a risk of infections, and particularly now in the COVID-19 era, I think it's important. And a child that we treated in clinical trials, and this is how the child looked after treatment. And this is the last study, 6 months to 5 years. Again, it is approved for infants now, and we all have these infants with a very severe atopic dermatitis that we can consider a systemic, again, clear-cut results of EASI 75 and IgA 0/1 in a very severe patient population. So, to summarize, atopic dermatitis is characterized by Th2 and Th22 upregulation in skin and blood across all ages. Different age groups present some age-specific features, such as Th17 elevation in infants and Th1 increase that begins in adolescence. And circulating proteins related to Th2 and cardiovascular risk are present from childhood and adolescence. Infants show the most active disease proliferation, and tape strips, I hope I convinced you, are able to identify AD-related markers even in the setting of non-lesional skin as compared to healthy skin. And, you know, I'm giving the talk, but this work was done by multiple people. So this is our department. My lab is also, some of them are here. And this could not have been possible without amazing collaboration from Amy Paller. Thank you so much for your attention.
Thank you so much, Emma. That was really great and stimulating talk, and we're slightly ahead of time. So if there are one or two burning questions, I think it would be great to take them now while people are fresh. But if we do run a bit behind later, we'll store them. Andy.
Yeah, two questions. One, you didn't mention asthma at all. So did you try to characterize the different patterns in the AD patients who had asthma versus not asthma? And then I had one other one, but go ahead.
Yeah, so in the studies we've done, we just, we actually did, so we looked, because reviewers asked us, because, right, a question may be, oh, your systemic activation may be due to the fact that they have asthma, right? Not because of the skin disease. So actually we looked, and there was no difference between patients that had asthma versus those that didn't have asthma. We are doing, though, now a different study, a collaboration with an asthma physician, and we are looking more carefully because in the patients we had with Amy, we didn't have FEV1, so we didn't have the asthma characterization. So we are doing something now, but the short answer, even patients that had AD alone had the same systemic immune activation in blood, similar to patients with asthma. So it wasn't the asthma that was responsible for that. What's the second one?
You know, in the psoriasis field, for me, we've got the answer with IL-23 as the master cytokine. And I thought, I had hoped that IL-13, you know, was going to be the same result, but we know we don't get the EASI 90, EASI 100 numbers like we get with PASI 90, PASI 100 with 17 and 23 blockers. So what do you think is missing? Of course, IL-13 is important, but we don't, if we block it, we still don't get these incredible clinical responses. So what is missing, what is still missing that?
Yeah, that's a wonderful question. So I think atopic dermatitis is a more heterogeneous disease if you compare to psoriasis. And my wishful thinking is at some point to see maybe a bispecific targeting IL-13, IL-22. Maybe that will tackle more of the spectrum of AD, depending on the phenotype. But I think time will tell. It's a very exciting time, I think, in atopic dermatitis. So, okay. Thank you so much. And I want to introduce Valeria Oki, that I don't think that doesn't need much introduction. She is a key opinion leader in atopic dermatitis worldwide, a very prominent leader in South America, and she is coming from Brazil, from São Paulo, where she wears multiple hats. She does clinical work, she also has a lab, and I'm super excited to have her give a talk today. Valeria.
Thank you so much for the kind introduction, Professor Gutman. I don't see my talk here. Can anyone come here and assist me? It's a blank. Yeah, it's a blank screen here. Is there a technician here?
Yeah, we don't seem to have the different presentations visible on this slide.
It's a blank screen. It says that support will be here soon. Be patient. So anyway, thank you very much for this kind invitation. It's been an honor to be here. And I'm representing Brazil, South America. And Professor Gutman here explained very much how diverse this disease is according to the ages. And the next question is, do you believe that patients from different ethnicities or races can behave in a different way in terms of immunophenotypes or even response to treatment? That's a big question. We're still learning from these target treatments. So let us see what we have with data regarding different races and ethnics, as long as the technician arrives. But while we wait, I think it's very important, especially for the young dermatologists, to join the IEC. I think the IEC, as here the chairs discussed, and also Robert Bissonnette, it's a golden opportunity here to be involved with this exciting disease. Okay, so I don't think we're seeing the lectures.
To start.
Yeah.
Okay.
Oh, while we wait, does anyone here in the audience need to ask more questions to Professor Gutman? Professor Gutman, I have a question for you. Do you believe that the response of those children is different if you consider a child that has been submitted to a previous immunosuppressant treatment with the regular immunosuppressants and then starts the dupilumab versus a kid with no systemic treatment at all? Do you believe that the immunologic trajectory will be the same?
So I do see some differences in those that were treated with multiple rounds of prednisone, for example. It makes the disease harder to treat. And from my experience, these children may take longer. It's not that they will not respond, but I will not expect maybe for them to be clear at 16 weeks. You need to give it more time, 20 weeks, 24 weeks, and definitely explain to the parents that you need to also use topicals to really achieve 100%, because sometimes there is this expectation that is unreal, that we put our child on a systemic, so tomorrow the child will be clear. And I think it's important to adjust that expectation.
Mm-hmm. Thank you.
So Emma, I'd like to follow on from a question from Andy about the data that you showed, which was really quite striking. And I wondered if you'd stratified for filaggrin amongst the children data, because we know that there were some subtle differences in adults, that it's not a question of it being a completely distinct molecular endotype. But I wasn't sure what the deal was for children.
So we actually did look at filaggrin mutations, and I believe that we had around 10% with filaggrin mutations in the whole database. So it didn't allow us to do real stats between the two, but we didn't find any unique characteristics in those that had the filaggrin mutations compared to the others.
Okay, well, I think we're back on track.
Yes, okay. So let's start. So my theme is the evaluation of atopic dermatitis regarding the different severity scores among different populations. So represented the University of São Paulo. And the topics here will be, first, the definition of skin of color patients. Second, the atopic dermatitis context in those skin of color individuals. Is it different? So we will cover epidemiology, immunophenotypes, filaggrin, skin barrier, clinical features, and finally, how is scoring atopic dermatitis in those patients? Shall we proceed the same way we do with the Caucasian European patients? That's a good question. So definition. First, who is the population that is named skin of color individuals? So according to many definitions, race or ethnics depends on a conjunction of factors. So it includes the phenotype, the genotype, but also social and cultural environment. Like in Brazil, for instance, black people, and in Brazil we say negro, it's a self-declared thing. So it all depends on where you live. And according to the US and UK definitions, skin of color populations would involve African or black individuals, Hispanic or Latinos, Asian or Pacific Islanders, American Indian, Native Alaskan, Indigenous Australian, populations from the Middle East, Arabia, and Northern Africa, and all those individuals who have biracial or multiracial or non-white background. So that's the definition. And in fact, there's a very good article involving populations of skin of color at the Blue Journal, the Journal of the American Academy of Dermatology. There are two parts. It's a very good reading for just introducing this theme. And they cover different diseases as well. And for you to have an overview of different races, how does it work? This is just an example. Let us take United States of America, a huge country where you have a multicultural and multiracial population. Here is the US 2020 census. And how are all these ethnicities distributed along the census? So the three top ones are still the white population, close to 58%, Hispanic Latinos about close to 20%, and Black and African Americans around 12%. This has been changing over time. In the previous census, the white population was close to 70%. So the biracial or multiracial ethnicities are growing little by little. I think here in Europe, you are more homogeneous population, but in the Americas, the New World, I think this is different. And in terms of atopic dermatitis in patients of skin of color, the epidemiology, do we know everything about the epidemiology of this disease in those patients with within different races? So here are some facts. First, atopic dermatitis is more prevalent in patients of skin of color, especially in the US and the UK. They have many papers regarding this theme. Second, the prevalence in the pediatric population is larger in the patients of skin of color. This was a census from 2003. And the AD in the non-Hispanic population and different racial ethnic groups is different. So AD is more incident and more prevalent within those populations. So here's the data. And if you see, here is the study from 2003 showing that African Americans is close to 16%, multiracial about 15%, European Americans close to 10%. And in the studies from the National Health and Nutrition Exam Survey from 2005 to 2006, the overall prevalence of AD was close to 16%. And in the black population, it was close to 20% in comparison to the whites, 16%, and Hispanic Latinos, close to 8%. So it's different, the epidemiology. We do see more atopic dermatitis in patients of skin of color. Second, immunophenotypes. Thanks to Professor Gutman and her team, we know much more about the immunophenotypes regarding racial and ethnics. How does it look like? So far, we know that the Th2 response is also the predominant type across all races. But there are some differences. So in the Asians, for instance, you see much more Th22 and Th17 in comparison to the African Americans that they hardly have Th17 or Th1 response. So this is different. And if you look below, here you see the IgE serum levels. It's much higher in African American patients than the European descendants. And the other point is the filaggrin mutations. All the studies, I think Professor Irvine here, who was responsible for a lot of those discoveries, we know that the European population shows much more loss of function of filaggrin mutations than Africans, for instance. So it's opposite ways. And this is the initial approach, but we do have more biomarkers coming. We know that now we have a different, more clusters with more biological markers in the search of a good precision medicine. And I think these new theories and when there's new markers, we have to know how all the diverse races will behave. So we still have a lot of questions to answer. And it's a very exciting time, as Professor Emma Gutman said, because this will be directly related to the precision treatment. And we must know how these populations will behave. In terms of filaggrin, I think Professor Sandipar from India will explain this more, but just to have a look, this is how the skin of color populations present in terms of filaggrin mutations. So we know that Asians are in second place after the Europeans in terms of these mutations, and we know that patients with more filaggrin mutations will have a more severe prognosis and more persistent disease. It's more rare in Black patients, but those who have also the filaggrin mutations also will have a more persistent disease. And the Hispanic and Latino population, unfortunately, we still have more questions. We have only one study from Chile where they found that filaggrin mutation was related to more severe disease, but this was not significant. So we need more. We need more studies, and this is an invitation for you from different regions to join those research studies. And there is one study from the Black population showing that filaggrin-2 mutations may be also related with persistent disease in Black children. So this is an overview of what happens with those mutations. In terms of skin barrier, Professor Alexis from also Columbia University publishes a lot about skin of color patients. And what we know about the skin barrier and atopic dermatitis is that here is a table. He published this article. It's an excellent review regarding atopic dermatitis, skin barrier, and what is the management approach for those patients. And here, I think we can stress that Asians, for instance, they show a weaker barrier strength and slower recovery, and their skin is considered more sensitive to many chemicals, for instance. The second point is that Blacks had increased spontaneous desquamation compared to those with white and Asian skin, and that's true. And another point is higher dryness scores were observed when you compare Blacks versus whites. And this, I think we are all clinicians as well. We see that despite a very good systemic treatment, we still need hydration, especially in the Black descendants. So many questions to be answered here. In terms of clinical features, this is the interesting part. We are dermatologists, and I think our keen eye is very important here to diagnose and avoid misdiagnosing the severity of atopic dermatitis. And this is what this lecture is about. So we know that African descendant patients, they show much more papules, hyperpigmentation, or sometimes post-inflammatory pigmentation. As you can see here in this publication from Professor Gutman and her group, showing here a very prominent perioral dermatitis with hypopigmentation, and also those cases that we see a lot in African descendant patients, this hypopigmented lesions after inflammation. So these are some signals that we cannot see in the Caucasian population. And here there are two patients from my university hospital. So you can see those papules and also perifollicular lesions that are very relevant in the African descendants. And also a very prominent lichenification. Look at here, this region. And also we know that African descendant patients also have a prominent Danny Morgan signal, as you can see here, and also a hyperpigmentation of the periocular areas. So all the signals are relevant to those patients, and sometimes if you don't pay attention, thinking only about erythema, for instance, you may misdiagnose the severity of the case. The second point is the topography. So if you consider white patients, usually we learn as first-year residents or medical students that atopic dermatitis most of the times is more prominent in the flexural regions, and this is true. But, however, when you consider skin of color patients, this may be different. Look at this patient here. They have the same age, and this patient here have the extensor involvement. And again, look, those papules, those lichenification lesions, and also hyperpigmentation. So these are different signs when you consider different races. And Asians, you know that São Paulo, my hometown, is the second place where you can find Japanese descendants, about 2 million. So we have a lot of Asian descendants. And here in Asians, we also see a lot of lichenification and a lot of desquamation. And really, those patients, usually when they develop facial lesions, they are much more prominent to have contact dermatitis, for instance. And that's what we read in the previous paper from the review from Dr. Alexis, showing that sometimes the Asian skin is more sensitive. And here, look at his hands, you know. It's a lot of hand and feet dermatitis as well. So these are sometimes different features that we see in different ethnics. And what about, the color? Color is something different. We have a publication from Professor Girolamo from Italy and some coworkers that we made a study comparing phenotypes, AD phenotypes, and we know that the color is different. If you think about European patients, erythema is erythema, it's red, and we have, a full grade of redness. And the VIGA scale, for instance, is based on the erythema tone. And we cannot do that with patients of skin of color. So Asians and Africans, they usually have different tones, more to the violaceous grade or even gray. So these are all aspects we have to consider when thinking about different ethnicities. And the other thing that I talked about, the extensor involvement and the prominent lichenification. Another point is that sometimes we see more than the regular AD phenotype. We have nummular dermatitis, we have prurigo nodularis, and in some reports from Japan, prurigo nodularis, when you have a patient with severe atopic dermatitis, it may reach up to 50% of those patients. So this is something that you have to pay attention. Erythroderma happens in about 5 to 25% of atopic patients. And again, I'm going to show you later more pictures of erythroderma. And it's very different if you consider white skin versus skin of color patients. And the follicular dermatitis, so this is really something that is prominent in African descendants. So we must be aware because this may be an important sign of active disease or sometimes flares. Whether those beautiful modifications that Professor Gutman discussed previously, whether the Th17 upregulation, for instance, in the Asian population will interfere with those clinical phenotypes, or IL-36, for instance, in the study from a black population in Tanzania, would enhance the lichenification. We still don't know. We need more studies regarding this matter. And finally, do you trust the scores when you're thinking of skin of color patients with atopic dermatitis? Maybe in Europe it's easier because you have a homogeneous population. But like when we are in our clinic in atopic dermatitis, sometimes it's not that easy to make the scale. So let's see the reason why. have a look at this paper. It's one of the classic papers regarding scores in atopic dermatitis. It's way back from 2002 from the British group from St. John's. And in this paper, they discussed the reliance on erythema scores because the erythema may interfere with the final score, and you may be misdiagnosing a severe atopic dermatitis, especially in black children when compared to the white counterparts. So the conclusions of the study show that black children with atopic dermatitis are 6 times more at risk of having severe AD than their white counterpart. They also emphasize that general practitioners and also dermatologists should note that erythema can be a misleading indicator of severity in black children, and more training is needed. And difficulties of assessment due to skin pigmentation might mean that severe cases are not being detected and appropriately treated. So this is a problem. So this was studied in 2002. Many years passed, many severity scores were developed, and finally, there was initiated called HOME, Harmonizing Outcome Measures. This initiative had the intention to join a group to discuss which severity score would be better, at least for clinical trials, and second for just regular clinic. So I think we have to establish this because sometimes it's really difficult to standardize those patterns. And this excellent study from the Australian group from Professor Didier Morel was performed 15 years later than that former study in the UK. And what this group found, interesting things. They chose to run EASY. That was the score that was chosen by the home group. And this score showed that there was an excellent inter-rater and intra-rater reliability for patients of all skin colors, supporting it as the outcome measures, the ideal one at least, to run clinical trials for patients, either if they are white or if they are skin of color patients. And they were expecting to find the same things that the previous group proved, that erythema was something that could condemn this severity score. But in fact, when they removed the erythema, they didn't have any changes. And when they included the erythema, it was still trustable to evaluate patients from different skin colors. Okay? So I think this is an important point. I think we can trust the EASY scores, but maybe we can have a different look on the erythema. And these authors propose a grayscale because, you know, in Asian but more black skin, the tones are different, violaceous or gray. So they propose maybe you could use this grayness scale. This could be also an alternative, for instance, in places where those populations are more prevalent. But this is not necessary once the erythema here was proved to be trustable, okay? But we have to maybe check in all different types of severity scores. So I'm going to show you some patients just for you to see the different colors that we have. This was one of the first patients that we used tacrolimus, and see, when she was in crisis, she had this different color. And when she was treated with topical tacrolimus with excellent response, this was her original color. She's a biracial lady, which is very common in Brazil. So we must have a different look in terms of erythema. However, we have to consider many other options, like lichenification, right? Even her Cushingoid-like face. Look at this boy. He was also in the trial for tacrolimus for kids. And look, when he was active, so a lot of desquamation, inflammation, and probably he was with a very high EASY score here, right? With edema. And then after 16 weeks, he was much better. And he was 0.03%, because at that time, we could not use higher concentrations. So this is the difference of tone. Here, you can hardly see erythema. We know it's erythema because it's a severe patient, right? And look at these papules here on his feet. And considering the time previous to the immunobiologics, we have here a patient, also one of the first patients that was able to use methotrexate. And look, when he was with active disease, there was erythema, in fact, but with a different tone, more to the violaceous shade, right? And here, you see a lot of those papules and lichenification in the extensor regions of his legs. So again, different. After the treatment, how are you going to consider that he improved? Of course, the violaceous color is gone, right? So he improved. It means that the erythema in the black skin was over. But still, he has some hyperpigmentation, but look at the amount of papules. So in this case, you should consider this as a sign of improvement, the disappearance of those papules. And finally, I think I'm going to show you, this was an interesting paper that is going to be published. It's already, you can download it, but it's interesting. It's a phase 3 with upadacitinib and skin phototypes. I was always complaining with the industry that whenever we see papers about clinical trials, we hardly see photographies of patients, right? So it's important for us because we know that the medication will work, but we want to see the lesions. So in this paper, we took patients from different skin of color tones, and then top one. We know that erythema is different. If you see here on the left side, you see a Caucasian patient versus a skin of color patient, right? So erythema is different. Second, one of the items was to evaluate excoriation. In the white skin, it's easy to see excoriation, right? Those lines, the scratches, it's really easy. But if you take the dark skin, it's really hard. So look here, you can see some points of scratching. So scratching is not a good sign for skin of color patients. And here's just for you to compare. This is a Caucasian patient with atopic dermatitis, severe one, look, easy, close to 45, VIGA4, which is the top of the redness, and after upadacitinib, 16 weeks, excellent response. The erythema is totally gone, very easy to detect. Here, one African descendant patient. How can we evaluate erythema? It's so hard, but look what happened to his lichenification. So here it's week 4, then week 16. So a lot of difference, right? So this was EASI 42 here and EASI 16 with EASI almost 0 and the VIGA 1. So these are different parameters that we have to think about when considering those patients with skin of color. And the final message here, these are 3 patients from our clinic, so you can see that Brazil is also a diverse country and an excellent place to perform studies with biracial or multiracial patients, because there's a mix of all those races. And if you see here a Caucasian patient with atopic dermatitis, an Asian patient with atopic dermatitis, and this lady, an African descendant patient from Brazil, look how lichenoid her lesions are and how hyperpigmented those plaques are. So this is different. I think these images won't lie. First, if you consider skin of color patients, they have more atopic dermatitis. The disease is more prevalent and more persistent. Second, those unique features, clinical features, are very relevant for you to have the follow-up and to evaluate the efficacy of the treatment. The erythema is something that you have to consider in different races. Severity scores should be carefully performed in those patients of skin of color. And the patterns of immunophenotypes associated with the genetics plus those new biological markers, they will hopefully determine the efficacy of those precision treatments. And we have to perform more studies in terms of different ethnicities. There was a paper saying that in the US, the African descendant patients were well included, but didn't happen with the Hispanic population, which is even higher in the US than African descendants. And the other question is, sometimes those patients with skin of color, they have more difficulties to access the physicians or even the healthcare system. So there is here also the social aspect of more severe disease, right? And the final point is that skin of color patients are still underrepresented in the global clinical trials. So I would like to thank you very much, and especially for the board of directors and the IC for the support, and also for Margaret Young, Alan Stiles, Josephine, and Jennifer, who are always supporting us, and also Stephanie, who's outside for this event to occur. Thank you very much.
Thank you so much for this very brilliant presentation. I think we have some time before the break for some questions. Anyone, please come to...
I have a question for you, Professor Gutman. In fact, you have a lot of experience, and in the US, I think those populations are very well represented. What's your experience in terms of clinical trials and efficacy of those new medications?
Yeah, that's an excellent question. In fact, I think, you know, in the dupilumab studies, and I hope I'm mentioning the right number, there were only 6% African Americans, and I bet a lot of them were from Mount Sinai in New York, where there is, you know, a lot of representation of African Americans. But I think we need to, at our center, we make an active effort to really reach these communities and try to include them in trials. And I think this is really important because at the end, we need to serve all the patients. You know, there are some cultural barriers maybe to have them in trials, and not only African Americans, there are other communities that from our experience, for example, in the United States, patients from an Indian descent also, it's hard for them to participate in trials. So I think there are ways to make a real effort, because at the end you want representation of all the ethnicities, since the drugs need to work similarly in these patients, and you need to know that during the clinical trials. Other questions, Robert?
Yeah, very good, very interesting talk. You mentioned, and there's additional literature going into that direction, that doing EASY and other measures of evaluating atopic dermatitis in patients with dark skin, when you look at intra and inter-rater variability, it's still fairly good. Dermatologists are still fairly good. However, often these studies are done by people who see a lot of dark skin patients. Mm-hmm. So my question to you is, there's a learning curve when you start to use EASY and SCORAD in any type of skin color, in my experience. Do you think that the learning curve in dark skin patient is the same as in lighter skin patient? In other words, does it take more time before you're good at doing those evaluations if you are just starting to use them in darker skin patients?
Yeah, I think we need to make adaptations to use those scores. Like the VIGA, if you read, you're based on the erythema tone, right? So I think that maybe for those patients, maybe the gray scale would be better. But I think we need more studies, because this publication from 2017 didn't include too many patients. I think we have to extend this and try to use, for instance, this gray scale to see if it still maintains the same scale as the erythema evaluation.
So, by the way, fantastic talk, thank you very much. And I think you raise a really important topic that's relevant to the management of AD in not only trials, but also ongoing registry studies. We must try and ensure representation. And that involves really talking to communities and reaching out. We're very keen on that in the UK with our support from NIHR, who really place a high priority on designing information leaflets and consent forms that are kind of appropriate to the communities you're coming from. And they may be interpreted differently. It isn't just a question of the language, it's a question of the semantics. So I think we do need to make a big effort to be as inclusive as we can. And then on a kind of technical level, I just wonder in terms of measuring the degree of inflammation in the skin objectively through, for example, Doppler studies or anything of that kind, whether people have tried to evaluate how they, kind of compare to the redness or gray scales, because it may well be that using an objective measure may get around this confounding pigmentary issue.
Mm-hmm. Yes, I think comparative studies are needed so far. Yes,
yeah,
Professor?
no, I agree with what was said, and I think actually biomarker studies are also very important in this population, because many times you see patients that you see disease all over the body. In fact, I teach my fellows how to do easy scores in clinical trials, and sometimes I see in patients with African American skin that have the disease all over the body that their easy is not what I think it should be. Mm-hmm. And actually, when we look at the biomarkers of these patients, they have amazing hyperplasia, they have inflammation. So I do think we need to have more experience in treating these patients and scoring these patients appropriately. Yeah.
I think this is a very important issue you have raised, Professor Valeria, that all these scoring systems in skin of color, I shall be talking about it, but I am not going into the scoring system. I have other things to share. Mm-hmm. But I thought this is very relevant, as Professor Robert has also mentioned about it. And I think we had a similar kind of discussion virtually, where Professor Nick mentioned about this Dopplers and other things to see the erythema, which we hardly see in skin of color. And if you see carefully, erythema is a very important factor for all the scoring systems for atopic dermatitis. But do we really see erythema in skin of color? Actually, no, right? So we have trained our eyes to an extent to assume to a degree that this is probably erythema. So let us be very honest with it. But that is our assumption. So how far that is evidence-based proved, we need to really look into it, need to really evolve or develop parameters, and probably in the days to come, a separate scoring system for skin of color should be developed, and which other organization other than International Eczema Council, which represents the global platform from 25 countries, 28 countries, 125 members. I think this is the actual platform to develop such criteria or scoring system.
Excellent point, Sandy.
Thank you.
Thank you.
I have to comment on that. I've been dermatologist 30 years and mostly trained in places with skin of color. And so I grew up University of Miami, lots of color skin. And then now I've been living in Portland, Oregon, which is all white.
Just the opposite.
And the dermatologists there, well, I don't know how to look at, I don't know how to diagnose skin of color, blah, blah. And for me, it's no different than white skin, because I think that's how I was trained. So I think where we are trained in those early years, if we're seeing lots of different types of color, then it doesn't become a big deal. For me, it's an easy and a black person white is the same. It's not more difficult. But for those who don't train early on with skin of color, it's very difficult, I think. It throws them off. So that's my theory about this is where you learn dermatology. What do you...
Oh, and another thing, there's a paper from the Australian group showing that when they performed the same evaluation, because the paper that I showed, it was in person, right? So the physicians were looking at the patients. But when they performed this with pictures, with photographs, the results were not that good. So I think a lot of training should be done.
Yeah, no, I agree completely. And even for me, I did residency in Israel. I didn't see at the time almost any skin of color. And then luckily I did residency in the United States, in New York City, where I saw a lot of skin of color. But I think as an organization, we need, maybe the IEC needs to do a lot of education, I think, on the skin of color. Because not all residency programs, you actually raised a beautiful point, not all residency programs, not in the United States, and I think not throughout the globe, are used to seeing these patients. And I think they need more education, particularly when it's not your bread and butter. Any other question? So we'll take a short break, and we will be back to continue at
Yeah, if you could be back here, please, at 10 to 4, and then we can carry on with 2 further excellent talks coming. Thank you very much.
Yeah, thank you.
Okay, well, I think for the purposes of time, we should restart. So I'd like to invite Sandeep Pandar to the podium. And it's my pleasure to introduce him as the professor and head of the department of the Pediatric Dermatology Unit at the Institute of Child Health in Kolkata, India. He's been a long-standing IEC counselor and is a key member of the IEC Education Committee. He's been really fundamental to establishing pediatric dermatology as a subspecialty in India, and he's also got an interest in cutaneous drug reactions. And in fact, earlier this year, he helped to found the Society for Eczema Studies, the first organization of its kind in Southeast Asia, and he currently serves as the president of the organization. And as you'll see from his biography, which is published in the pamphlet, he's published widely and given a number of invited keynote lectures. So today, again, we're going to have a focus on pediatric dermatology, here discussing filaggrin gene mutations in the Indian subcontinent, and again, continuing, I suspect, the theme of skin of color. So thank you very much.
Thank you very much, Professor Nick Reynolds, for your extremely kind introduction. Thank you, Professor Emma Gutman, for chairing the session. Esteemed and distinguished colleagues and friends, I bring warm greetings from India for all of you. Well, at the very outset, I would like to sincerely thank IEC for giving me this opportunity to present the Indian scenario atopic dermatitis. I am sure that most of you are probably not much conversant with that, what has been happening on the front of atopic dermatitis in India and subcontinent. So this is a unique opportunity, and this is exactly the very important quality of International Eczema Council, which embraces the entire world. This is my conflict of interest, though I have been a key opinion leader and advisors to many multinational as well as national companies. I don't have any conflict of interest here as far as this presentation is concerned. Now I shall talk a bit on filaggrin gene mutation, which we did in Indian pediatric atopic dermatitis population. And then I shall switch over to different types of presentations of atopic dermatitis seen in our skin. Subsequently, I shall discuss about something more. The first question will come, the filaggrin gene mutation, those started way back in 2006 or maybe 1 or 2 years earlier. Even you will see that even last year also there is a publication on filaggrin gene mutation. That means this is something which is ongoing. Professor Emma Gutman has shown involucrin, loricrin, and many other genes which are coming up. But still, filaggrin gene mutation has got its own importance. And second reason is, India has the largest pediatric population in the world and largest atopic dermatitis population in the world, though the incidence of atopic dermatitis is around 7%. But considering the population of pediatric population below 14 years of age, the large number of pediatric atopic dermatitis we get to see. And they come from different ethnicity. I'm sure that many of you will be surprised or rather shocked to know that more than 2,000 ethnic populations' home is India. More than 4,800 religious populations is, the hub of India. So there is wide diversity. Why I am saying all these things? Because we have been discussing so long the heterogeneity of atopic dermatitis and phenotypic, genotypic variations. And one single molecule will not be effective for all types of atopic dermatitis. Blanket treatment, whatever it may come, it may be dupilumab, it may be nemolizumab, one single molecule will never be effective for all kinds of atopic dermatitis because of tremendous heterogeneity in the different populations of atopic dermatitis. So we carried out this study because it was not carried out earlier, keeping in mind that FLG varies from 14 to 56% by and large in the published studies, and FLG null variants are distinct and in each population. There was no Indian studies when we carried out it, in our population. And basic idea was to see the filaggrin gene polymorphism in Indian children with an attempt to do a phenotypic, genotypic correlation in various forms of atopic dermatitis. And the methodology was basically, it was a prospective observational multicentric study of 75 Indian children. Sample size is small because the cost of this investigation is very high, this was supported by Indian Society of Pediatric Dermatology, and we had limited fund. It was a study carried out over 2 years period, and the diagnosis was made as per Hannifin and Brackus criteria. Something which is more important, that many of these studies is actually they have addressed the particular, exome of the entire filaggrin. There are 3 exomes. The exome 3 is the biggest exon. So we did the entire filaggrin genes next generation sequencing technology. So this is the flow chart of our study, participants. I'm not going into detail. You can read it on your own so that I can save some time for subsequent panel discussion. This is the clinical characteristic of 75 patients. And as you can see that age-wise, there was not much, difference. So also the severity-wise also. So most of the studies highlight that if there is filaggrin deficient mutant or different filaggrin mutations, so severity of atopic dermatitis is going to be high. In our small population, in small sample size, we didn't find that. That was something very interesting. There are something more which we are in for surprise actually. I'm going to share with you that. Total number of children with FLG null variants were 26. Prevalence of loss of function mutation or LOF mutation was 34.7%. Total number of FLG LOF variants were 20. 16, that means 80% variants were unique or novel, which has not been described in European studies and in other Asian studies. Mainly the other Asian studies been carried out mostly in China, Japan, Singapore, Korea, and Malaysia. So this is the filaggrin LOF variants, busy slide. We found only with correlation with 2 variants. One is variable factors. One is the age, and second one was the IgE level. There are 7 variants which were detected in more than one individual. Total number of children or more than one variant were 13. 11 patients, that is 42.3%, had 2 null variants and 2 had 3 null variants. However, there was no difference in genotypic, phenotypic associations, neither the severity in children who have 2 null variants versus those who have got 3 null variants. So this was mostly an academic exercise, you can say. So to conclude from this study, that this study documented high prevalence of FLG variants. The FLG variants identified were both unique and novel to this population, not reported in any database, particularly in Indian scenario. Because we have Asian and European descents in our country, presence of one or more FLG mutation in an individual did not correlate with the severity of AD, which I just now mentioned to you. There was significant association of FLG variants with early age of onset and elevated serum IgE levels. Here I must say that this study is now ongoing through Society for Eczema Studies, about which I shall be talking in a short while from now. And we are planning to do in large number of patients. So we have arranged funds for that. And the shortcomings of our study, let me accept that these are the limitations of our study, is a small sample size, and because of that, either there can be fortuitous positive result or false negative results. We are fully aware of that. So I hereby acknowledge all those who participated in this study. Dr. Shahana Srinivas from Bangalore was the principal investigator. There are many actually basic scientists. There are many geneticists involved in it. Some of them are dermatologists. It was a team effort actually. The same team will work, probably with addition of few more, for a large number of patients to study. Now, the next part is that I am going to share with you the kind of clinical presentations of atopic dermatitis we see in India and subcontinent. There will be some amount of overlap with Professor Valeria, what she has shown, because I shall also be talking about the skin of color, but I shall take it from a different angle. For this reason, I am showing this conflict of interest slide. Well, more than 2 decades ago, we published this series in pediatric dermatology, a prospective study over 6 years period of 672 children with atopic dermatitis. We found the classical presentations, as Professor Emma mentioned, that why in children the face and extensor are more involved. That was a wonderful description with all these interleukin factors and cytokines involved with it. A very nice explanation of it. But we know that in since childhood the lesion starts encroaching over the flexors. Often there is secondary infections by Staphylococcus aureus, which is again, as it is said, most of these studies have shown in filaggrin deficient patients, herpes simplex infection, Staph aureus infection is more common. However, in our patients we didn't find. Lichenification is very difficult to treat. Here I must say that in Indian scenario or in the subcontinent, what we say, I always tell my juniors and students that atopic dermatitis, whatever you read in the Western textbook, you do not see that in majority of the patients of atopic dermatitis in Indian scenario. You see classical atopic dermatitis in only 30% of the patients. You see minor forms of atopic dermatitis in 70% of the patients. And severity of atopic dermatitis, moderately severe to severe atopic dermatitis, by and large between 20 to 25% patients. What do I mean by, minor forms of atopic dermatitis? Often the children are brought to us by the parents, doctor, the child cannot walk, having burning sensation, and this is going on for a number of years. With this type of presentation, we know it. It is 4-foot eczema or juvenile plantar dermatitis. But where is the difficulty of labeling it as an atopic dermatitis? I think we should label it as atopic dermatitis. All these minor forms I prefer to label them as atopic dermatitis, because the moment you label them as atopic dermatitis, there is a world of change in your approach, including counseling. You tell the parents that, look, this is a very chronic disease and it is not going to disappear within few months or few years. It is likely to recur every year for many more years. So that is my basic intention of highlighting these minor forms of atopic dermatitis, which is more common in India and subcontinent. Eyelid dermatitis, bilateral eyelid dermatitis, often the children are brought with this. The doctors, these are not going in. And the pediatricians are saying, don't bother, you just apply a little bit of steroid. They are keeping on applying steroid on the eyelids for months together. So here you have to really chip in and diagnose it as atopic dermatitis. And when we diagnose them, you take the personal and family history of atopy. I do IG also, and most of the patients, all these factors come positive. And we label it as atopic dermatitis with eyelid dermatitis specifically seen. And it is an evolving disease. Atopic dermatitis is an evolving disease. So over a period of time, you have to see whether the child is developing lesions. We have been actually following up these children. And many such children subsequently throw lesions of classical nummular eczema, flexural dermatitis, and all these things. Our rheumatologist colleague often quote in their presentations, this is their very favorite quote, think lupus, then only you will be able to diagnose lupus. I say think atopic dermatitis, then only you will be able to diagnose that atopic dermatitis. Otherwise, you will just label it as eyelid dermatitis and let the patient go and let the parents, do doctor shopping from one doctor to another. This is another presentation of infra-auricular or retro-auricular dermatitis. Often I have seen my physician colleagues, they are treating it with as intertrigo with antifungal creams. Nothing is happening. So actually these are atopic dermatitis. And you have to tell the parents that, look, this is a minor form of atopic dermatitis. It needs the long-term treatment and follow-up. Initial treatment with topical steroids, oral antibiotics, if there is secondary infection, then moisturization along with antihistamines for a few months. And that actually takes care of the problem of the child. Many such children are brought to me by the parents saying, the doctor, my child complains of tremendous burning of the lips and cannot eat hot food or slightly, India is a place where people prefer spicy food apart from Mexican food. So it is spicy. It is a country of spicy food. So the child cannot take food because unless and until the food is spicy, we don't feel the taste of it actually. So this is atopic cheilitis. Often they present like this. And you have to treat it accordingly. Initially, mild topical steroid like hydrocortisone, followed by, pimacrolimus for a few months, hydrocortisone for 2 weeks, then moisturization along with antihistamines. And that actually takes care of the entire thing. And the parents are very happy, let me tell you. But you have to label them as atopic dermatitis with atopic cheilitis. Often what happens, the child, as a result of tremendous burning, just to give relief to the burning sensation, starts licking her or his own lips. As a result, this type of lip lickers dermatitis happen. Well, posterior thigh dermatitis is fairly common in our population also, both in small children as well as, older children. But the problem is what Professor Valeria highlighted, the hyperpigmentation. It's extremely difficult to treat. Now coming to another very important thing, this I often ask my pediatrician colleagues and dermatologist colleague, that by and large our concept has been over the number of decades that to develop lichenification, the eczema should be of some standing for 5, 6, 7, 8 years. Here there is a 5-month-old baby which was brought to me with excruciating pruritus over the vulva. The parents were totally tormented, devastated with the pruritus of this small baby. And this part of the globe I belong to, pinworm infestation is a very common thing for vulval pruritus. Anthelmintic was given, few courses, nothing happened. And look at the lichenification. Just 2 months of history of pruritus. And the degree of pruritus led to lichenification. So this challenges the very concept that atopic dermatitis or eczema has to be a few years of standing to develop lichenification. So it once again highlights that different types of skin, its heterogeneity, and different type of response in the same kind of stimulus. So you cannot simply put them in a blanket statement or a big box that, yes, these are the features. There is wide variability of presentations of atopic dermatitis as well as treatment response also. Counterpart of atopic vulvovaginitis in small children, this is very common in my practice. I often see such atopic penoscrotal dermatitis, which takes long time to go. And most important thing you can do is proper counseling of the parents, because they are very, very tense. Well, all of us know that approximately 30% of infantile seborrheic dermatitis turn over to atopic dermatitis. For a long time we know this. But here there is a 1-year-old boy, as you can see, with who started with infantile seborrheic dermatitis. And look at this excoriation, bleeding, erythema. We were talking about erythema in black skin of color, but there are 3 types of skin, Fitzpatrick skin, 3 types of skin, type 3, type 4, type 5, all exist in India. If you go to the northern India, like Kashmir and Himachal and northeast part, you will see white colored skin, type 3 skin. So here you can see this erythema, you can see the excoriation, you can see the cracked lips. So it is a transitional phase of atopic seborrheic dermatitis. Secondary infection by staph aureus is fairly common in Indian scenario. And we have published on that extensively, even from International Eczema Council also we have published in 2019. Another important aspect I shall come, which probably is not known to most of you, that this is the map of India. As you can see, those areas which are in red are extremely hot areas. Those which are in yellow are moderately hot. Only the green areas are colder areas. Hot areas means where almost 7 to 8 months, starting from March to end of September, this month, the temperature soars up to 30 to 45 degree centigrade, and relative humidity 80 to 95%. As a result, there is development of miliaria, and the miliaria leads to eczematization, or when it subsides with fine brownish scales. So this is miliaria. And looking at the face, I am sure that anybody who is not very conversant with malarial dermatitis would like to diagnose an atopic dermatitis in this child. And another interesting twist in the tale, let me tell you, friends, now this study is ongoing in our Institute of Child Health, that many such malarial dermatitis we have seen later on, they have been gradually converted to atopic dermatitis. So whether it is a coincidental or it is a precipitating factor of atopic dermatitis, only a large cohort will be able to find that out. And there is already an established concept in a well-known journal about the subclinical miliaria is the factor responsible for producing atopic dermatitis. Post-inflammatory hypo and hyperpigmentation, both are very distressing to treat, even around the lips also, for lip liquors dermatitis, posterior thigh dermatitis, they have shown you. This is very difficult. With any amount of treatment, they don't simply go. Another thing is lichenification. You see the kind of lichenification. Professor Valeria has shown you some lichenification in, type 4, type 5 skin. These are, even with the best possible treatment, they simply do not go. I must tell you here, one important observation we have made, though very small studies, only 25 patients study, because, dupilumab, there is, unlike many countries, it is not covered by insurance. Patients have to buy it from their pocket, and it is exorbitantly costly, all of us know. First study on dupilumab we published just, last year. What we found that dupilumab reduced the hyperpigmentation in children who had severe hyperpigmentation to a great extent. So only in the days to come, we'll come to know how much effective it is in reducing this hyperpigmentation, because so far we have not found a single drug, systemic therapy. This degree of lichenification doesn't go with any treatment. This type of lichenification. Now we have, earlier assessed the severity of atopic dermatitis in Indian children, but in northern Indian children, we found the severity is much less. We published that in British Journal of Dermatology, and it was more or less perceived that severity of atopic dermatitis was less in India, and this particular article was quoted in Rook's textbook of dermatology for 2 consecutive editions. But subsequently, there has been a paradigm shift over the last 2 decades. We have been seeing quite a number of severe cases, 20 to 25% cases. Earlier, we never used to see more than 5% cases of severe atopic dermatitis. So here lies the importance of systemic therapy, immunosuppressive therapy. Even 5 to 6% of our patients do not respond to cyclosporine or methotrexate. They need dupilumab therapy, or maybe JAK inhibitors in the days to come. So all these severity scoring and other things we'll collect data, we'll maintain registry in a very comprehensive way, and that's why, friends, the Society for Eczema Studies have started on 28th March of this year in India. It is just slightly older than 5 months. It is the first society of its kind, though there are many societies across the globe. The first society which will extensively and very focused way study atopic dermatitis and other types of eczema, but by and large atopic dermatitis. It will do research, collect data, because what I have told you earlier, here I am showing you in figure, the incidence of atopic dermatitis today is approximately 7.2%. Now, India's population is 140 crore, of which 26.6% is below 14 years of age. So that comes to 37.2 crore pediatric population, the largest in the world, with an incidence of 7.2% in atopic dermatitis. The atopic dermatitis pediatric population comes to 5.16 crore, which is 5 times more than United States, because it is slightly less than 1 crore. So, but we don't have enough data, because nobody has ever taken the initiative to collect data in a very comprehensive manner. And hence, the Society for Eczema Studies has been created to promote academic activities, to promote research, to collect data, to maintain registry in the field, and to do conferences, webinars. There are various committees, like academic committee. I'm very happy that Professor Deepankar De is here from India. He's from PGI Chandigarh. So Deepankar, could you please stand? He is our convener of academic committee. Thank you, Deepankar, for being there. So there are several committees, as you can see, more than 120 top academicians of Indian dermatology. They have joined this society. This is our national advisory board. And this is our international advisory board. I am very happy to share with you that some of the legends in the field have very kindly consented to be on international advisory board. It starts with Professor Amy Peller. I am very thankful to Professor Amy Peller, Professor Emma Gutman, and Professor Nick Reynolds, our 2 chairpersons, and many others. I approached Professor, Robert Vishnuet, but he very clearly said that it will be conflict of interest. I really appreciated his honesty, because he cannot be there on 2 societies. But I am sure that in the days to come, Robert will be on board. And he assured me that, Sandeepan, you don't worry, I'll support you from outside. Thank you, Robert. This is the website. And first national conference of SES is going to be held on 17th and 18th of December in Kolkata. That's it. Thank you very much.
Thank you so much for this very nice presentation. Do we have questions from the audience? I have a question. So what clinical trials are available right now in children in India?
Right. A very pertinent question, Professor Emma, as expected from you. Currently, we are undertaking a multicentric epidemiological and clinical data collection on atopic dermatitis in children. It will be from 40 centers across India. And basic structure of it, it was made by Professor Deepankar De and modified by our academic chairperson. And we are expecting that next 2 to 3 years, we will have a robust data on atopic dermatitis, and many unknown things which were not earlier noted will come to know. Very comprehensively we are doing it, and with proper statistical evaluation and taking proper help of the other associated specialists like pediatric immunologist, pediatric pulmonologist, so to see the atopic march and all these things. Second, we are doing a study on proteomic studies, which you have mentioned, the wonderful study which you have carried out with TAPE method. We are planning a proteomic studies. We are planning a metabolomic studies also. And we are planning, we have already started the initial part of extending this filaggrin gene mutation because we found very interesting result. And we believe that if we do it in large number of patients, something more interesting may come up.
Any other question? Valeria?
Thank you, Sandipar, for your excellent talk. I have a question. You showed India map showing very hot areas on the west side of the country. How do you deal with the dry skin in those areas? Because you showed a lot of miliaria. What is the adhesion of the patients? And do you see any difference in terms of clinical follow-up regarding the dry skin?
This is a wonderful question, Valeria. This is exactly what we face in our country. And I often tell my students and junior colleagues that, see, atopic dermatitis is a double-edged sword for us. That means in northern part of the country, during winter, because of extreme dryness, the place from where Professor Deepankar comes, Chandigarh, where I have studied in the Premier Institute, PGI, or Delhi, or Kashmir, or Himachal, so there it is freezing cold. Temperature goes below, -5, -6. In Ladakh, it goes below -20, all of you know, Leh Ladakh. So there are areas, pockets in India, where the temperature goes down like anything. During that period also, atopic dermatitis aggravates because of the dryness. These are the places where the humidity is also very low. Not like the other places, central part of India, particularly east, where from I come, Calcutta, and the western part, Mumbai. So these are the coastal areas where the humidity factor is the main factor during summer. As we know in Hanifin-Reicher's criteria, one of the minor criteria is itch when rashes, right? Sweat leads to itching, right? So these are the situations when there is sweating and the itching. In atopic dermatitis, we see that during the summer. But another thing I would like to share with you, that of late I have been seeing, because there is an economic growth and development of India over last 5 years or so, now even in the rural or urban, semi-rural areas, many children, they sleep in the air-conditioned room. And I invariably ask the parents, do your child sleep at night in the air-conditioned room? Yes, doctor. Then I tell them that please moisturize the child. Otherwise, during summer months, either the parents don't want or the child doesn't want to apply moisturizer all over the body because they complain it gives the very sticky sensation.
So
Thank you.
Thank you so much. I think we'll limit it to this is the last question because we need to move on. So I'm really excited. So thank you so much.
Thank you. Thank you. Thank you very much.
So I'm really excited to introduce the next speaker that is also a very dear friend of mine, April Armstrong. I don't think she really needs much introduction, but I'll shorten it. So she is an Associate Dean of Clinical Research at the Keck School of Medicine, where she's also the Vice Chair for the Department of Dermatology. She's very well known for her research, multiple clinical trials, works on outcome research and effectiveness research, and published a lot, and is also an editor for several journals. So April, I'm very excited for you to be here.
Great. Thank you very much, Dr. Gutman and Dr. Reynolds, for the invitation. Today, I'm going to talk about biologics and JAK inhibitors in special populations. In the area of atopic dermatitis, my research team has mostly focused on outcomes research as well as technology-enabled delivery of care. I also want to acknowledge my fellow, Paige Kingston, who has been working in this area with me. So we'll get started. Here are my disclosures. So today I'm going to talk about 4 different special populations, and they are the geriatric patients, also talking about patients with potentially cardiovascular risk factors and what our systemic medications in atopic dermatitis can potentially modulate those risks. Also, the third population is the immunocompromised population. And then finally, we're going to talk about the pediatric population, kind of bring everything to full cycle to where we started. And the JAK inhibitors that I'm going to talk about specifically are abrocitinib, upadacitinib, biologics, and for the biologics, we're going to talk about tralokinumab as well as dupilumab. Now, the first topic I'm going to talk about is the geriatric patient population. Now, believe it or not, I have been called a geriatric patient. Now, I do want to tell you the context. So when I was pregnant with my first child at the age of 38, my OB, who is also obviously a physician, who said, "Oh, you are considered a geriatric pregnancy." Now, when I heard that, I wasn't too pleased because I hadn't really associated the term geriatric with myself at the time. And I said, what happened to pregnancies associated with, mother of advanced maternal age? And he's like, oh, we changed the term on that. So you're considered geriatric pregnancy. But when we're thinking about clinical trials, geriatric patients, typically we're looking at patients 65 years or older. And as this cartoon says, that my bones are getting softer, my arteries are getting harder, so it balances out. But they are a very important patient population, and they're ever growing in many parts of the world. And they are typically a patient population with a number of different comorbidities. And we, as clinicians, treat them quite gingerly. So we need to really know what are some of the effects of our medications in terms of both efficacy as well as safety in our geriatric patient population. So first, I'm going to talk about upadacitinib, our JAK1 inhibitor. And I want to orient you a little bit with regards to this slide. So I'm going to talk about upadacitinib. And here I'm showing you EASI-75 response, monotherapy upadacitinib at week 16. And what we see here are the different breakdowns of the different age groups. So when we look at the overall trial results from this, the gray triangle represent that of the placebo group. There, my cursor works, and then as you can see here, the green represent the response in the overall patient population when they're treated with upadacitinib 15 milligrams. And then the blue square here, what you see is patients that were randomized to the upadacitinib, the higher dose, the 30 milligrams. And then when we look at the breakdown of the different age groups, what we see is that, for example, in the age group of 18 to 64, which is the majority of the patient population, you see a nice separation in terms of the response. So you get a dose-response relationship between the 15 milligram group versus the 30 milligram group. But what happens when we look at those that are age 65 and above, what we see is that here the green circle and the blue square, they overlap. So this tells us that in the older population, it didn't really seem to make a big difference whether they are treated with 15 milligrams versus 30 milligrams. Now, there is something to be taken into consideration. Overall, this is a smaller population that we're looking at in terms of the clinical trials. So I would say larger investigations are necessary in order to know if that truly makes a difference. Similar findings we also see in terms of the IGA 0 or 1, clear or almost clear, in terms of the outcome. At least in the upadacitinib pivotal studies, what you can see here is that the 15 milligram versus the 30 milligram didn't have the separation that we see in terms of dose response as with the other age groups. So one thing that is noted is that we talked about the efficacy didn't seem to be that much difference in the older population, 15 versus 30, taking into the caveat that it is a smaller population. Another thing that was also noted in the clinical trials is that when you're looking at the treatment emergent adverse events, when you're looking at the older group of patients, what was noted is that those adverse events actually occurred in higher rates when you give them 30 milligrams versus 15 milligrams. So when you evaluate this data in totality, as the FDA has, now here's efficacy in the older population, 15 versus 30, not a huge difference based on the clinical trials. Here's safety, you have higher rates of geriatric patients being on 30 milligrams, having overall total exposure-adjusted higher rates of AEs with the 30 milligrams compared to 15 milligrams. So ultimately, as you can see, these data played into probably the decision-making that the FDA had in terms of the upadacitinib labeling, which is the dose of 15 milligrams a daily in patients 65 years or older. So this is a recommended dose for that. Now, what about their combination study? So now I'm talking about upadacitinib plus topical corticosteroid. And here, as you can see, in the combination studies, you actually do see a bit of separation here, dose response in the older group. I'm going to switch gear and talk about abrocitinib. So abrocitinib here, another JAK1 inhibitor predominantly. And here what we see is that we don't see 65 years and older. So here the age breakdown is different. Here the older population is 51 years and older. And we are trying to ask two questions. Number one, is there a dose-response relationship between those who are on abrocitinib 100 milligrams versus 200 milligrams? And in the older population, is that response comparable to the younger cohorts? So let's attempt to answer those questions. But before we do that, I just want to point out, again, this is a smaller population compared to the overall patient population. So what we see is that, first of all, there is a dose-response relationship. So your blue bar of 100 milligram abrocitinib is lower than your orange bar of 200 milligrams. And we see that across the different age groups. And importantly, when we look at the height of the bars, they seem to be comparable. So in the abrocitinib group, you do see more of a dose-response relationship in the older patients, and you also see in terms of the overall response to be similar to the younger cohorts. Here is abrocitinib monotherapy EASI-75, a different measure at week 12. What we see, same trends that I talked about earlier, also hold in with this particular outcome measure. And here we're looking at itch, so PP-NRS scores at week 12 for abrocitinib. Again, we see a dose response between the 100 and 200. So the 200 is going to get you better itch relief at week 12, and also the response seems to be comparable across the different age groups. Now let's talk about safety events for abrocitinib in the elderly population. So here we have several safety events of interest here. We have the serious infections, we have cancers, both skin cancer as well as internal malignancies. We also have MACE events and VTE. And I've put red arrows to indicate where the geriatric population is. So here the geriatric population is 65 years and older. And the blue bars represent 100 milligram groups in terms of AE, and the orange ones represent 200. So what's the takeaway here? Well, it's kind of difficult. Number one is that due to the small sample size in the 65 years or older, what you see are these really tall 95% confidence intervals, right? So these not 95% confidence intervals are big because it's a small sample size. There's variability. Variabilities in the small sample size can really drive what we see here. So the takeaway from this is really in terms of these special interest of events of interest, we do probably need to have larger studies in older populations in order to understand the real risk, if there is any, or if there's potentially amplified risk for these different outcomes. But overall, you do see an overlap in terms of the confidence intervals, with a caveat the confidence interval for the geriatric patients is a lot higher. There are several things that were noted in the safety profile of abrocitinib, and that's important to note. One is that it was noticed that there were higher likelihood of low platelet count, low lymphocyte count, as well as higher rates of herpes zoster in the 200 milligram group compared to the younger cohorts. As a result, in the package insert, there's recommendation for especially noting these different laboratory parameters in the elderly population. So I think when we are treating with, our geriatric patients with some of these JAK inhibitors, my takeaway is that it is especially important to monitor their hematologic parameters when we're treating them with the JAK inhibitors. All right, I do want to remind everyone we are in Milan, and Pinterest reminds me that these are the images of the glamorous grannies of Milan, since we're talking about the elderly population. And I have to say, I only wish that if I go into my golden years can look this glamorous, I would be pretty happy. So. Now, we're going to pivot to dupilumab in the elderly population. So here is a multi-center retrospective observational study. So this is not a clinical trial data. This is an observational study looking at 276 geriatric patients on dupilumab. And what they looked at here, the older group is actually on the left-hand side. So here, the older group is the greater than is the green bar here. So they looked at the older cohorts versus the younger control groups, and they looked at outcomes of EASI, itch, sleep, as well as quality of life. And what you notice is that overall, what they found is that there were not a lot of differences in terms of dupilumab patients that were treated, older patients that were treated with dupilumab, in terms of their symptomatic relief on clinical signs and symptoms, itch, as well as sleep. And I think this probably mirrors a lot of our clinical practice and experience with dupilumab, that we have older patients who do generally also respond pretty well to dupilumab. Now, moving on to tralokinumab in the elderly. As we know, tralokinumab it has been out in the US for several months now, so we're accumulating our evidence on tralokinumab. And again, a small cohort when you're looking at actually those who are 65 years and older. But what was found in terms of that patient population with regards to the overall incidence of AE is that it does tend to be lower in the elderly population than actually the younger cohort, which is something that actually was a bit surprising to me. And when you looked into this more specifically, what was found was that the AE flares were lower in the geriatric population compared to the younger cohorts. And also they noted there were lower rates of viral upper respiratory tract infection. So if you're wondering what's driving the overall lower rates of AE for tralo in the elderly population, mostly are fewer flares in that particular patient population. Okay, now cardiovascular risk factors, JAK inhibitors. There's just so much to talk about. There's so much context around here, around this. I think that there are two studies I will highlight in this particular talk. And the first one here is actually a review article that looked at JAK inhibitors and cardiovascular risk that's published in 2022. What is shown here is, first of all, they put together, summarized the oral surveillance study, which is a very well-known study looking at the arthritis population, predominantly RA population, in terms of their cardiovascular risk with regards to tofacitinib and in comparison to TNF inhibitors, mostly adalimumab. And why this study is very important is that this was the genesis of the change in the labeling for the JAK inhibitors, and also the translation of that labeling across the different JAK inhibitors. And specifically, I want to focus on the AE rates, the cardiovascular event rates. So this is expressed as events per 100 patient years. And what we see is that in the arthritis population, for tofacitinib, we have event rates of anywhere between 0.9 to 1, depending on the dose of tofacitinib per 100 patient years in terms of a cardiovascular risk. Now here, the TNF inhibitor, again, mostly adalimumab, is 0.73. Why this is important to show is that it's important to understand history and where some of our labeling came from. And this is what was shown in the oral surveillance study. Now let's look at our the drugs that we use for atopic dermatitis, our JAK inhibitors. Here we have abrocitinib and we have upadacitinib. So when we look at the AEs, adverse cardiovascular events per 100 patient years, abrocitinib here is around 0.6, and then upadacitinib in the AD population anywhere between 0.2 to 0.4, depending on the study that you're looking at, the dose here as well. So what do we learn from this? I think 3 lessons. Number 1 is that when interpreting JAK inhibitor results, especially when it comes to cardiovascular risk factors or VTE, we need to look at specifically at what patient population we're looking at. Why? Obviously a different disease, different concomitant meds. Number 2, there are drug-to-drug differences. And number 3, there are dose differences as well. So it's very important to understand the context and making sure that the comparison group that we have when interpreting these results are properly contextualized so that we can provide accurate information to our patients. Now I'm going to switch gear a little bit, and then in the topic of cardiovascular disease, highlight the study that looked at vascular inflammation in patients with moderate to severe atopic dermatitis. Now, our group has done some work around epidemiology of this topic in both psoriasis, and we're doing it in atopic dermatitis as well. The AD literature in this is actually more mixed than that in psoriasis. So there are epidemiologic studies showing, yes, there is link between AD and especially moderate to severe AD with vascular inflammation, coronary artery disease, and there are also a number of negative studies that have been done as well. In this particular study, and the reason I'm highlighting it is that it looked at a number of more granular factors. So what did they look at? They looked at vascular inflammation as measured by FDG PET. They looked at a skin immune profile. They also looked at a blood immune profile, which included microparticles in the serum. So as we know, microparticles have been shown to be correlated with cardiovascular disease, especially our atherosclerosis. And so they looked at both patients with moderate to severe atopic dermatitis as well as healthy controls. So if you look on the right-hand side, what we notice is that when we're looking at these different microparticles, basically surrogate for coronary artery disease and other vascular inflammation, we see that between the healthy control and those with the moderate AD, there were some differences there, but the difference is really amplified between the healthy control and then those with severe atopic dermatitis. Now, this is a small study, so we do need to take that into consideration, and I think larger studies are necessary. One thing they did also look at is the dupilumab treatment. So what they did is that they treated the AD patients with dupilumab, and what they saw is that overall an improvement in their SCORAD. And what they've shown, if we focus on the right-hand side, is that the improvement in the SCORAD is generally seemed to be correlated with atherosclerosis signaling cytokines. And those cytokines included IL-1RN, IL-36A, IL-36G, and so forth. So I thought that was quite interesting, that the improvement in SCORAD, however you get there, seems to have a correlation with the decrease in some of these atherosclerosis signaling molecules. Okay, now we're going to switch gear to our immunocompromised patient populations. So the data in this area, unfortunately, is quite scarce, especially with our JAK inhibitors in the AD population, I shall say. However, there are some real-world data as well as case reports for our biologic population with regards to dupilumab. So there have been multiple, when we look at the literature, there have been multiple case reports that have been published looking at dupilumab in HIV-positive patients. And when you look at those case reports, and there may be a publication bias there, but when you look at those case reports, overall, what they showed is that there had been no exacerbation of the viral load. So most cases have shown either unchanged viral load, and there's some showing some decrease in the viral load. But overall, suggesting a safe use of dupilumab in patients with HIV. There was also a case of a patient with chronic hepatitis B on entecavir, which I thought was interesting, which also showed that dupilumab use in those cases did not lead to reactivation. Now, there's likely not a good mechanistic rationale why dupilumab would interfere with some of those pathways, but I think it's always nice to see real cases being reported in the literature regarding the dupilumab use in the immunocompromised patients. Here's a case of dupilumab in a patient who had undergone liver transplant. So transplant patients, liver transplant patient who had been on immunosuppressive therapy for tacrolimus. So what was intriguing to me is that this patient still had a lot of excoriations, was itchy, had these, more a bit prurigo-like nodules on immunosuppressive therapy on tacrolimus. I would think tacrolimus would have cleared this patient's AD, but this patient still had a poor quality of life, so was then placed on dupilumab, and therefore considered for this section of the talk, clear with dupilumab overall, and the patient did develop moderate conjunctivitis at week 22 of the dupilumab treatment. But overall, good, that did not require discontinuation of dupilumab. So overall, good response of dupilumab in a transplant patient. Now, I'm going to go to the last part of my talk, which is looking at the pediatric patient population. Now, when we are thinking about the pediatric population, I found apparently in Milan, there's a Milan Kids Fashion Week. It's not this week, but apparently a good sense of fashion is instilled when people are young here. So looking at abrocitinib data, when we're looking at abrocitinib data here, we're looking at really the adolescent data, so 12 years old to 17 years old. And as you can see in the abrocitinib studies, 50% moderate, 50% severe. The sample size is small, and we know that with abrocitinib, we do not have the adolescent indication there. And what we do see is that in the adolescent population, you do get, for example, number one, the dose response that you get from the jump in the increasing efficacy going from 100 to 200 milligrams. And the response is overall comparable to the adults. And then here is the abrocitinib EASI-75 response, as you can see here, at 12 weeks. So again, you do get an increase with 200 milligrams compared to 100 milligrams in the adolescent population. And overall, the response rates were pretty similar to those of adults. Here we see itch data. So here is PPNRS, proportion of patients who achieve 4-point improvement or more. And what we see here, also similar themes that I talked about, that there is a dose-response relationship in the adolescent population, and they seem to respond comparably to the adult population. One thing that was noted when they look at the AE profiles of the different age groups is that nausea does seem to be more common in the younger patients taking abrocitinib. So that is something to note. What about upadacitinib? Switching gear to looking at upadacitinib, here is our EASI-75 monotherapy at 16 weeks. So as you can see here, for the adolescent patient population, we do get a bit better response with the 30 milligrams compared to the 15 milligram group. And here is clear or almost clear, IGA 0/01, similar theme here in terms of the dose response. It is observed in the adolescent population as well. And here is a combination therapy of upadacitinib plus topical corticosteroid therapy. So with a combination, as you can see, if you push the dosage to 30 milligrams of upadacitinib, you get about 75% of the patients achieving EASI-75 by by week 16. So I think this study probably mimics more real-world use where you probably have topical corticosteroid or some kind of topical medication as an adjunct to systemic therapy. So as you can see in the adolescent population, in the combination therapy, 75% achieving PASI 75 at week 16. With a 30 milligrams, and lower 56% with a 15 milligrams. All right, so I showed you fashionable kids. So apparently there are these fashionable kid-mom combinations as well. This is definitely high couture Italian style. And this one is actually my favorite, not from the internet really. I love it. The kid is a little spider and mom is like a spider web. So I like that combo. Just so that the dads don't feel left out in the audience here. There are baby dad fashion. Apparently, you can find anything on the internet, as you can see. So this brings me to the last part of my talk, which is pediatric patients and the use of biologics. And here is tralokinumab in adolescent population. So tralokinumab, our IL-17 inhibitor here, what we're looking at is the adolescent population, age 12 to 17, and we're looking at clear or almost clear at week 16. Monotherapy, very important monotherapy. So what do we see? We saw that, interestingly, whether you're on 150 milligrams or 300 milligrams, didn't seem to make a big difference in this particular patient population. As you can see, the two mimics very close to each other. And at week 16, compared to 4% in the placebo, about 20% of tralo-treated patients achieved clear or almost clear at week 16. And here is the same trial with the EASI-75 data. So what we see here is that monotherapy tralokinumab in adolescents, what we see about close to now 30% of patients achieving EASI-75 by week 16 compared to the placebo. Again, it didn't seem to make a huge difference whether you're on 150 milligrams versus 300 milligrams. And now switching gear to dupilumab, as you have already heard, that dupilumab is approved for, has been approved for a while now for children aged 6 months and above. So this is a combination, so this is Dupi plus topical corticosteroid, and what we see that is about 28%, nearly 30% of the patients on dupilumab plus topical corticosteroids achieve clear or almost clear by week 16. And this is the results for one same trial looking at EASI-75. So now you have essentially more than half the kids, young kids, if you give them Dupi plus as needed topical corticosteroids, half of them will achieve EASI-75 by week 16. And importantly, when we look at the itch data here, so if we focus on the graph here for the itch data, by week 16, they will have noticed about 50% reduction in itch. So with that, I'm going to show you my fashionably dressed 2 boys that I gave birth to as a geriatric mother. But I want to thank you very much for your attention.
Thank you. Thank you so much. Really amazing presentation. Thank you. Just one comment, because the study you presented was actually a collaboration of me and Robert Bissonnet, the cardiovascular study. So we didn't have actually patients treated with dupilumab. We took a historic transcriptome of dupilumab-treated patients, and we just basically, it was a bioinformatic exercise. We asked whether dupilumab can modify in that cohort. It's not that we had dupilumab treatment.
Yeah, April, would you mind just going back to the podium? Because it's quite nice if we can just have a couple of direct questions, and then we can move on to the kind of wider discussion.
So that was a terrific talk. I loved it. Thank you. Looking at the efficacy data and the safety data in the older patients on JAK inhibitors, has anybody looked to see if that is due to renal dysfunction? Because the drugs have to be, excreted through the kidneys, and there's a warning that with decreased renal function, you have to, worry about the higher doses. So I'm wondering if you don't see that 15-30 effect so much because the 15 staying around longer because there's more renal dysfunction. If there's ever been a correlation with, say, creatinine and
I think that's a very good hypothesis, Dr. Blauvelt. I think I haven't seen that particular correlation being made, but I think that's a very good hypothesis. And also probably, with the clinical trials, if their parameters were too out of whack, that they may be excluded, but yeah.
Yeah, could I just follow on from that? Because I think that, we're all slightly anxious about prescribing JAK stats in the elderly, with the potential for cardiovascular risk. So I note you presented the data in terms of 100 patient years, but I think it's often presented as relative risk, which is kind of slightly easier for the physicians to understand in terms of that particular direct population. So is there enough data yet, or should we be really encouraging people to collect data in registries so we can really get a grip about whether, it's very hard, isn't it, to substrata relative risk amongst ages and know you're doing the right thing?
Yes, I think we should definitely encourage people to collect more data. I think more data is really going to inform our clinical decision making. And especially when we're looking at VTEs and MACE events, they're rare events. So, if the overall population is small, 1 or 2 events can really skew the numbers that we see. So, yeah.
So April, I have a question. What are you in real life doing? Let's say you have a 75-year-old with severe AD coming to you. How are you having the patient conversation with that patient that, let's say, needs a systemic? And if you feel comfortable putting that patient on a JAK inhibitor, and if yes, on what dose?
Yeah, so I think if I have a 75-year-old with moderate to severe AD, I have to say I probably think about our biologics, Trelo or dupilumab first. And the reason being that especially dupilumab has a good track record overall in the patient population. And then I worry a little bit less in terms of some of the laboratory abnormalities. Now, if it's a 75-year-old who has very few comorbidities, but who have a very severe disease burden that really needs a greater relief, I would monitor the patient carefully and consider a JAK inhibitor when I put the patient on. And I think I would definitely monitor the laboratory parameters to make sure that I avoid they may be the one that may have lower platelets or lymphocyte count as a result. So I think I would consider all treatments, but it really depends on their comorbidities, and that will be the key in terms of driving my decision making.
Yeah, no, definitely. Any other question? If not, you can still ask a lot of questions. I'll invite all the speakers to come to the podium, and we'll be happy to answer any question, either related to the talks, or if you want to ask other questions, that's also welcome. So please come.
Including Robert.
Yeah, and Robert.
Can I please ask if we've had any questions sent in through the kind of chat? Because we still haven't seen anything up here, and it's a little unusual. We've had no kind of questions. Please come and take a seat, everyone. We'll have to share mics, so we'll just somehow manage this. Can we have an answer, please, to the question about e-responses from our technical colleagues? Can you find out for us?
Yeah, we don't see any questions submitted. What did we take? No, we want to ask if people submitted questions because we are not seeing. No, we know that, but we don't see any of the questions. I mean, we can just have the audience ask questions, but maybe there are some questions already submitted.
Okay, we'll just crack on, I think. So, while people are thinking what to ask, so maybe we could just start, because I think it's been a really great session with discussing different subgroups within AD, both in terms of age, geography, skin of color, and so one thing that we could perhaps start a bit of debate among the speakers is to what degree do the changes we see reflect genes or environment, which is always one of the key questions we have in AD. And it's, I think, particularly relevant to the discussions that, that we had, around the Indian population from Sandipan about extreme heat. So we, you described this very distinctive phenotype. Is that seen in other genetic subgroups within India? Clearly people may migrate there and stay. So it'd be useful just to see to what degree we feel this is due to genetics. I mean, I think the US is a good environment, isn't it? Because the environment is pretty static and you've got great variation. I don't know if Emma wants to kick off.
Yeah, no, I completely agree, and I think I like that we ended with treatments of different populations from different perspectives, pediatrics or the older population. And I think when we consider treatments, I think we need to be guided by definitely safety on one hand, but on the other hand, we need to remember that different populations may need targeting of more than one cytokine pathway. So sometimes, even if we want to give a biologic at a certain age, sometimes we need to target a little bit more broadly to really achieve success. And another thing that I think we need to also keep in mind when we have the discussion with patients, some patients just would say that they prefer an oral medication. So you need to consider many, many aspects when you have a patient in front of you, because some patients, no matter how you will explain to them about safety, just the fear of needles will drive them to prefer an oral. And I want to open this up for discussions.
Yeah, I think there are so many phenotypes and endotypes of atopic dermatitis. It's definitely a more heterogeneous disease than many other inflammatory skin diseases that we see. I do think the genetics drives a huge part of it. And as we have heard from all the great talks today regarding that, I just want to add one environmental factor that our group is looking at is air pollution, which I know there are a number of other great groups that are also looking at that. But in Los Angeles is a great place to study air pollution, and it seems to, at least our preliminary findings, that that air pollution does seem to affect, not surprisingly, in a negative fashion in terms of some of the AD exacerbations in our patient population.
Yeah, right now I think in IAC we are talking about preparing a paper publication on pollutions and climatic changes. I think very well thought out, and this type of publications is not much there in the entire literature. People have searched it. So as Professor April very rightly pointed out, the air pollution. One thing I want to once again emphasize for all of you, particularly for our residents and junior colleagues, that you should remember that atopic dermatitis is a unique disease. Its name started with atopic, means something which is unique. It still has remained unique after 6 decades of its discovery, right, or first being described. Unique in the sense that heterogeneity, genetic polymorphism, presentation in different racial, ethnic populations, and response to treatment. In so many ways, it is different from other diseases, chronic diseases. So atopic dermatitis, I must say, is much ahead of psoriasis, treatment-wise, follow-up-wise, diagnosis-wise. It always keeps us for surprise.
So,
Yes.
yeah, please go ahead with your question,
Okay,
and we'll continue the debate.
I am Fernando Valenzuela from Chile, and I would like to ask you if you have any experience in combination therapy with most of the treatments you have mentioned, patients are okay but not perfect. So do you usually use phototherapy or any other combinations?
You know, I think the answer may be different in different parts of the world, I think. So I'll give you my answer that is true for New York. You know, we are bound also sometimes by what insurances will allow us to do. But let's say in an ideal world in which insurance, because insurance, if let's say I approve the patient on a biologic, it's highly unlikely that the insurance will allow me, through the insurance, to put the patient on another modality that will be adding cost to the insurance. But in an ideal world that the patient can pay out of pocket, so, and the patient has availability, so phototherapy is something that I do use sometimes, but we need to remember that that's good for patients that have all the time in the world, students, they will not be able to do it, people that work, you know, it's hard to go twice a week to the doctor's office. The light that is at home many times doesn't work as well. So, you know, there are many considerations. In terms of giving a biologic and a JAK inhibitor, for example, I usually do not do that. If I consider that a biologic is not enough, then I will just transition the patient to the JAK inhibitor or put the patient on a clinical trial. Imagine the insurance company, first of all, they will not agree, but imagine the added cost also to the insurance. We need to consider that, and also you don't want to add two treatments. So I think the answer is yes, depending which treatments. And we need to remember now we also have very good topicals that got approval. And the first thing that I would do, I would make sure the patient is on a good regimen of the systemic treatment I gave the patient plus a topical before I try to switch them.
So I think I can perhaps comment from a European perspective that we're not so regulated by insurance issues, but we're more governed by safety. So we rarely, if ever, I think have combined a biologic and a JAK. But we do tend to use biologics with methotrexate, particularly if patients have responded well before, they've lost response to methotrexate, you transition them onto one of the biologics and they respond for a while and then they start to lose a response. That's quite a common thing we see. And if they haven't completely failed, we can rescue them with low-dose methotrexate. And I think that seems to be a pretty safe combination. We've got quite a few patients on that now. And then if that fails, then we would switch to an alternative JAK. That tends to be our therapeutic order. Does anyone else want to comment?
I think for me, probably if Dupi or Trelo fail, then I would switch to JAK, probably skipping the step that Professor Reynolds just said. But I agree, topicals, adding topicals if your patient is willing can really boost that efficacy. But I think in the future, it's, our systemic therapies can get, still have a bit of ways to go, especially in the biologic realm. So I think combination is something very important to think about.
Thank you. Thank you.
I think I have a question. We know that refractory patients, when they get the biologics or JAK inhibitors, sometimes they improve a lot. How would be your treatment if a young girl or adolescent or young woman desires to get pregnant? What would be, the safety zone for stopping those medications and starting pregnancy? Because Th2 is a very relevant axis for pregnancy.
Yeah, no, that's an excellent question, and this is a very relevant question to all of us. I think we are asked all the time, and we all have patients that we maintain, for example, on dupilumab or tralokinumab, then the patient wants to get pregnant. And I'll tell you my answer, and I think that's individual. I tell them, listen, it's not approved for pregnancy because there was not an official study done. However, there were patients that were reported that kept the treatment and delivered healthy babies. And, I cannot force you to do each of the things I'm willing to continue the treatment during pregnancy if they elect. I document in my note that I had that discussion. I also tell them that I can transition them for phototherapy. And whatever they choose to do, we are doing. I can tell you that we had multiple cases that continued treatment in pregnancy and delivered healthy babies. So I think it is safe. But we cannot, I don't think in a legal fashion, we can basically tell them to continue treatment. I wonder actually what others are doing.
Yeah, I generally would treat them with Dupi. I say I feel comfortable treating you with Dupi probably until through the end of the second trimester, and then we can consider stopping it during the third trimester when you have your FC receptors, more expressed on the placenta, which there's a higher likelihood of Dupi potentially being taken across placenta. We are in a data-free zone, so in the U.S., I completely agree with Dr. Gutman that you definitely want to document. You had this conversation, about potentially risks that's associated or not associated with the use of the medication before proceeding.
Undoubtedly, biologics has changed the quality of life of many children with severe atopic dermatitis, particularly in connection with dupilumab, with which I have got experience. I don't have experience with other molecules. But I have definitely seen that those patients who are not responding to cyclosporine repeated doses for adequate doses, more than adequate doses, even 6-7 milligram per kg of the body weight also. So they have responded nicely to dupilumab, and their quality of life has changed. And so the parents don't mind spending that amount of money from their pocket. So there is definitely huge scope of biologics, and some of the JAK inhibitors also, which are in the pipeline. We have to see for next few years that how do they fare, and only the test of time will suggest that how efficacious they are and how safe they are. We have to remember about both the efficacy as well as the safety part of it.
So I'll just go back to the question about the pregnancy, if I may, just to give the European view. And again, I think we're very similar here in terms of our risk profile. So our policy is to explain exactly, as Emma and April have said, that it's not licensed, and that we try and get the individuals and their partners to do a risk assessment themselves, and which should involve, I think, the kind of consideration of risk of having severe AD in pregnancy, which I think is an important consideration. But in general, we would, as April does, continue for the first trimesters if the risk assessment is favorable, and if possible, try and avoid it in the third trimester, really on theoretical grounds in line with what we do for our psoriasis patients, where there has been shown to be significant levels in infants born, for example, on TNF inhibitors. So we don't really know, as Emma said, what the data is going to, what it would mean to have dupilumab levels in infants. But those studies need to be done. I think if you do, try and measure the levels if possible.
What about the idea of disease modification? First of all, how do you think about disease modification with different treatments? And does the answer make you determine one treatment or another? I wonder what my colleagues think. Like in children, for example, are you considering the idea of disease modification when you give a treatment? I'll give you an example. You have an infant less than 5 years old, has severe atopic dermatitis. Do you go directly to a systemic after the child failed topicals for a few months? How do you convince the parents? Do you bring the idea that maybe there might be additional comorbidities like asthma later on, and trying to treat the entire atopic march? Like, what will be your thinking very early on in trying to prevent potentially additional comorbidities?
Sure, I'll take a stab at this. So I'm probably a bit more willing to put, and I've put, kids on systemics with AD, with our current modern therapies. And perhaps I'm looking at it at the lens of not necessarily molecular levels of disease modification, but how that AD may change this child's life course if untreated early on. So I'm looking more at their social interactions, their school, their lack of sleep at night. So in terms of disease modification, I think of it probably more from a psychosocial perspective, especially for our children when they're in those formative years, they're developing their identity. I think I can do a lot in terms of making sure that the AD doesn't put a mark on that, and that can potentially inevitably, change them into a person that they wouldn't be if they were not treated early. So I know this is a bit of a kind of psychosocial perspective on disease modification, but it'd be interesting to hear what my other colleagues.
I think this is a very, very practical issue, Professor Emma has raised, and this is the issue which we face in, day in and day out in our practice. And basically, I'm a pediatric dermatologist, that's why I face more. And the parents are very actually upset about this. And we have to remember that whenever you are treating a small child with atopic dermatitis, it's much different than treating an adult with atopic dermatitis. Adults understand, adult can express, the child cannot express. Treatment of a child with atopic dermatitis actually is the treatment of the entire family. Because if the child cannot sleep at night, lack of sleep, which you often quote as an important feature, how can the parents sleep? So it devastates the entire family. So here again, I will come back to my rheumatologist colleagues comment. They say that hit hard and hit early. So we have to hit hard and hit early. So there is no procrastination. Just moisturizer is the only thing which you can give. You cannot do a painting with the topical steroid all over the body. So what else you have left? You have left with only moisturizers, maybe a short course of oral steroid, antibiotics you can give. Then you go to immunosuppressive treatment, cyclosporin or whatever, methotrexate or whatever it is. But I won't waste time because it affects the quality of the life of the child as well as quality of the life of the parents as well.
I was wondering if you make the decision to put a child on systemic therapy, do you first start with the conventional systemic immunosuppressants such as cyclosporin and methotrexate, or do you these days switch immediately to a biologic or a JAK inhibitor? And the second question is, what is your experience with dupilumab in very small children in sense of that they need to get an injection every so often, because you can explain it to a 6-year-old maybe, but how do you do that in a 1-year-old that needs to be injected so often?
So I'll try to tackle the multiple different nuances here. So first of all, I do not, and in the United States, we do not need to start, thank goodness, with the traditional immunosuppressants, and I don't see why I should start with the traditional immunosuppressants if now I have approval of dupilumab. So I think the biggest job I have when I talk to parents is to convince them that they need to go for a systemic, because it's very hard for the family to understand that the disease is chronic and can lead potentially to other comorbidities, right? They try to ask me, oh, do you have a diet? You need to go through all of these, and I think there are studies that are showing that actually severe atopic dermatitis leads to food allergy, not the other way around. So you need to spend some time. And I do think that it is beneficial when the child is, of course, severe enough to put the child on a biologic. And the discussion that you have may be different by age, but we need to remember until 6 years of age, we only have a dupilumab. The JAK inhibitors are not approved, and in fact, also until 12, they are not approved. So only 12 and up, and not all the JAK inhibitors. Only one JAK inhibitor is approved 12 and up. So you need to know all of these considerations in order to put the right patient on the right drug.
wanted to address the injection frequency question as well. I oftentimes, tell my patients, the parents who have younger kids, that it is an injection that you'll have to administer, and the one thing is that is really emphasizing the benefit risks, right? So, but you're trading that with the benefit of your child can sleep well, and that they can thrive in school. So it is a lengthy discussion, and I think once that's been started, they know that injection is still a pain, but they see the benefit and they can see how much more the benefits really outweigh the injection pain.
Is it on now? Right. So I don't see children in my practice, but in the UK, there is still, according to our regulatory environment through NICE, recommendations that patients have tried at least one systemic before they move on to a biologic. So we generally would do that, though I tend to agree that the risks of being on cyclosporine and methotrexate are probably greater than being on dupilumab. But it's just what you have to deal with. The injection thing, I think, isn't entirely confined to children. So we have a number of adults who clearly see the benefit, but they then have major anxiety about the injections, and we have to counsel them and get psychological input. And with that, they can be managed. But otherwise, they kind of talk about getting the injection close, but that they can't quite deliver. These people have major anxiety issues over it for no obvious reason, despite understanding the great benefit they've gained. So they have these, I think it just illustrates the complexity of the disease that we're dealing with.
Yeah, no, I completely agree. Even though I'm not a pediatric dermatologist officially, I'm actually seeing probably a third of my practice is children. I guess many pediatric dermatologists don't want to assume a treatment of severe patients with atopic dermatitis, so I wind up seeing them. So I actually have quite some experience, and it's interesting, the children until 6, that's a discussion with the parent, and if you convince the parents, then it's no problem because they are doing the injections. And I would say that even up to 12, it's manageable by the parents. The age that I find the hardest are actually the adolescents, because then we have a discussion, all of us, and many times, I do put all the options, and many times they are electing an oral. At that time, you need to bring the patient, the adolescent, into the mix, and they are making sometimes the choice. And adolescents, many times I learned, it's hard for them with the idea of a needle. I mean, we try to explain, many of them will do it. Some of them elect to be on an oral.
I think we are talking about this something like dupilumab or other biologic which is injectable. We have to remember that these are not immunosuppressives. So if in case you are giving the child either cyclosporine or methotrexate, you have to do testing every 3 weeks or every 4 weeks, number of blood testing. That also amounts to injections. So basically, the child gets injections for the testing of the blood, biochemical and hematological testing. So, and at the same time, for dupilumab are the things you do not need, particularly for dupilumab, you do not need regular blood monitoring for that purpose. So that is the biggest advantage of dupilumab.
So I was reminded of the time. I think we are at time, but we want to really thank you for staying to this very end, and we hope that you found this symposium informative and helpful to your practice and increasing your knowledge. And I want to thank these amazing speakers. I learned a lot, and I hope you learned as well. Thank you so much.